effective patient-physician partnership for improved epilepsy care. And we're pleased to welcome Dr. Andrew Zillgitt, who's an epileptologist from Beaumont Health, Dr. Alexandra Shaw, a pediatric epileptologist from Beaumont Children's, and Cheri Compton, who's an adult with epilepsy, who will be sharing her personal perspective. And we also would like to thank Beaumont Children's for sponsoring this session. All right, so let's get started. Can each of you just briefly describe your background and kind of share some initial thoughts on this topic? Dr. Zillgitt, would you like to go first?
Yeah. Good morning. Thank you for including me. And my name's Andy Zillgitt. I work at Beaumont in the Adult Epilepsy Clinic or Epilepsy Center. And you know, I guess as background, I've lived in Michigan my entire life, and I live in this area. So it's I think it's important to be in the community where you work and do things. So that's just a little bit of background. I could go into more, but in terms of my thoughts on this topic, I think, you know, as effective patient-physician partnerships go, really, I think you can boil it down to just communication and interaction with people. I think establishing the rapport and then developing that open line of communication, because there is going to be a lot of information that is given. There's going to be some complicated treatment regimens, maybe even some complicated treatment options. There's a lot of diagnostic testing. And so throughout the process, I think what it really boils down to is having an open line of communication.
Okay, great. Can see Dr. Shaw, so we'll just wait to get her video going. And Cheri, do you want to introduce yourself while we're waiting?
Sure. My name is Cheri. I live in Holland, Michigan with my husband and 2 sons. I have adult onset epilepsy that was diagnosed 8 years ago. Oh, let's see. I've been through plenty of treatments and have had a few different types of seizures throughout. 4 years ago today, actually, I was admitted to EMU for surgical or intracranial monitoring. I also have the NeuroPace implant. And it's definitely important to have a good foundation with your provider. I have found that throughout multiple providers already, and I'll speak to that later, but it is the foundation of the care we receive and to really move forward in treatment.
Okay, great. Thank you for joining us. Dr. Shaw, we can see you. If you can just unmute yourself, should be all set.
Wonderful. Thanks so much,
okay,
Russ.
Great.
Yeah, sorry, I actually just had to switch to my phone. The local internet is blocking my use of the video, so sorry about that.
Well, thank you for the quick thinking and getting on the phone. So
no
you want to just briefly introduce yourself?
Yeah, hello everybody. My name is Dr. Shaw, Alexa Shaw. I'm a pediatric epileptologist. So that means a pediatric neurologist with special training in epilepsy. One of my great joys is meeting with families in the clinic, and I appreciate so much being included in this conversation about how to build a foundation of clear communication and trust from which both compassionate and effective care can take place.
Great. So as Dr. Zillgitt referenced, I think we can all agree that open and honest communication, mutual trust and respect, and shared decision-making are all important elements of effective patient-physician partnerships. So let's dive right into some of the specific practices to adopt and some of the pitfalls to avoid in order to maximize both seizure control and quality of life. So starting with communication, one of the biggest things patients and family members appreciate is responsiveness, and lack of responsiveness is a common frustration. Questions often come up between appointments, and there are many different ways to ask these questions, including healthcare portals, email, relaying them through a nurse, and so on. What methods of correspondence do each of you find most effective? And what are reasonable expectations in terms of the volume of correspondence between appointments and the timeliness of responses? Dr. Zillgitt, would you like to go first?
Sure. So I typically provide different resources for people to contact us. There's a line directly to our nurse, email, patient portal, even my cell phone for emergencies. The issue that I think I run into sometimes during busy clinic days or busy service days, I can't respond to every email and text in a relatively timely fashion. Our nurse is a little bit more equipped to do that. But I think for me, personally, I really enjoy the patient portal and or my chart as it's called. I think through anybody who has an Epic electronic medical record, because I think that keeps a running tally of what's going on. But I do have people share a lot of things through email, specifically their seizure diaries, which is really helpful as well. Because I think this comes up in another question. It really allows us to focus in on during their appointment on specific things. So I think all avenues, with technology, especially nowadays, are open, and I think they all work well. They all have advantages and disadvantages. But in a typical day, it's not uncommon to get somewhere between for us 20 to 30 calls on top of other things. So we try to prioritize those and get back to them as quickly as possible. I think we do a good job, but sometimes obviously things don't always go smoothly. But I think the reasonable expectation in terms of timeliness and response really depend on the acuity of the call or the message. That if it's a breakthrough seizure or a severe medication side effect, those need to be handled far more urgently than something about I have a question about an upcoming test. Maybe that's just from my perspective.
Right. So there's a triaging that sort of takes place in terms of messages. Dr. Shaw?
Yeah, thanks, Russ. On the pediatric side of things at Beaumont, we rely primarily on telephone and use of the MyChart patient portal just for PHI, wanting to encrypt and keep safe that data. And so we're not using email currently. So the two main portals for us are our phone and MyChart. And, just as Dr. Zillgitt mentioned, we encourage families, if they have a more high acuity question, specifically regarding seizures, breakthrough seizures, again, medication side effects, just like Dr. Zillgitt mentioned, nothing beats on the phone communication for those. We want to be able to get back to families immediately in some cases, if not, certainly by the end of a business day. MyChart is an interesting application and portal that we find facilitates communication about some of those questions about tests, like Dr. Zillgitt was mentioning. How do you set those up? Questions about maybe looking back at old lab data or results data. We find that that portal can sometimes be easier for some users than others, and we want to make sure that every family feels that they have a reliable and open source of communication to us, and also to make sure that they're contacting us in a way that allows us to get back to them as quickly as the request requires.
Okay, great. Cheri, what are your thoughts on this?
I very, very frequently use it's also MyChart for the health system I'm not in Beaumont. I'm on the west side of the state, but I use it for specific reasons. You mentioned keeping track of lab results and such, Dr. Shaw, and that's part of it. But as I write out messages, I can narrow down what my actual main concern is. And so that when I end up having lots of questions between appointments, because they range from anywhere between 3 to 6 months, further depending on provider and status. But it also allows me to go back and look at answers that I receive. Another reason is my doctor wants updates from me specifically. Because I had resection in 2016 and NeuroPace last year, it's an ever evolving thing. But he wants updates essentially monthly at this point, and he requests them. So I send it through MyChart because then it's there. I can say I did it. He can see it when he's ready. Otherwise, if it is something that needs more immediate attention, I do call. With rapport that I have built over time through that office, there are specific people that I do call for certain things. I have their direct lines. And that's how it's come to be, and I love it that way. Response time through my chart or portal messaging, 2 to 3 days, depending if I'm asking a question. If it's immediate, definitely that business day. For breakthrough medication issues, bigger things, just as the doctors said, those are important. Well, it's all important, excuse me, but.
Yeah, I'll just, I just would like to interject, and I think your what Cheri just said is right. With my chart, there's that running list, and you can always go back and reference that, and I think that's what's great about it. So, you know, in August there may have been a question that was answered, but now September there's something a little bit different, but we can reference back to what was written in August, and I think that's great, and I try to tell people I prefer to know as opposed, you know, kind of in real time what your thoughts and questions are, as opposed to 3 months later or 6 months later when you come in for a follow-up appointment. Now there's several things to address that have some level of importance. As you said, everything's important, varying levels of importance. So yeah, I like what you said about keeping that kind of, it's always there in the chart. I think that's nice.
When it's helpful, sorry, as a patient, with all the questions and all, I've gone through so many med changes and treatment plans, and lots of people with epilepsy do. That's not something uncommon. My questions will vary, and I do want to look back, as you said, Dr. Zillgitt, just because I have that information, and I will even screenshot it so I can pull it up quickly later if I'm discussing it with a member or another person in my care team.
Right. Right. I think it's the other thing you mentioned, Cheri, is just the idea of, I know this is true for me. If I'm writing something, I can be a whole lot more detailed and thoughtful about it. And I can go back and check and make sure I covered everything. Whereas if I'm talking, I can get flustered or distracted and not get all my points out. So I think there is an advantage to that as well. So being aware of each other's goals and priorities and coming to a consensus on that is also really important. For example, if a physician's goals are seizure freedom and safety, and the patient or caregiver has prioritized quality of life, those two objectives may not always be completely in alignment. The patient might be willing to accept more seizures and more risk if this means improved day-to-day functioning, fewer restrictions, and enhanced well-being. Can you share some examples of situations where maybe the goals did not initially align and how you worked together towards a consensus?
This is a challenging question. Who wants to start with this one?
Yeah, whoever wants to go first can jump right in.
I have it written down in front of me for conciseness.
There you go.
Yeah, please go.
And it's actually something I have discussed multiple times with multiple providers because of the surgical treatments I've gone through and the medications. We all know that these medications can have some pretty intense side effects. My doctor's goal and my ultimate goal really is complete seizure freedom, but there's caveats to it. My first seizure was witnessed by my 5-year-old son at the time. So now they're 13 and 12, but throughout all of this treatment, I have had to be able to take care of my boys. If I'm confused all the time, if I'm too tired and can't make sure their homework is done, everything that comes along with children, they're fed, they're safe, that doesn't work for me. And I'm I live with my husband, but I'm primarily taking care of them. Especially through surgical treatment, one of the biggest fears was loss of cognitive function, memory. And it wasn't a high risk, but I voiced my concern multiple times. If I'm not aware enough to make that decision, my family knew as well, I want to be cognitively functional. So don't do anything that's will make me less so. And that's not usually what a doctor will do, but it's a fear. I have children to raise, and quality of life, if I'm not able to do things independently, it's bothersome. And I voiced that to my doctor. My doctor definitely knows that.
Right. And then that's really important, because that can be kind of considered as a primary consideration with each treatment decision, each adjustment, each change of direction in your treatment course. So,
and it came up with one med specifically as well, outside of surgical treatments or options. That medication, it was an option, and he left it up to me ultimately, but there was decreased cognitive function, heavily known for it, that can take quite a while to adjust to, and at the time it just didn't work for my life.
Yeah, I would echo, I think one thing when you see an epileptologist, you're going to a comprehensive epilepsy center, our goals right from the beginning are no seizures and no side effects from whatever treatment that goes from medication side effects to even surgical adverse reactions, as you mentioned, maybe with memory or cognitive function. And so I think, there are challenges always with trying to balance that, and from the get-go, it's really medication side effects, because that's usually our first line of treatment. And so, I'm going to keep going back to this communication, knowing what the side effects are, as Cheri was talking about with the medication with, I think I can maybe guess what medication it is, but with relatively severe side effects of cognitive dysfunction or cognitive slowing, you just want to be open about what those are and align those. I think one thing that's important is that although, we never want to adversely affect quality of life, one of the things that we do know from continued seizures are those do adversely affect quality of life. So, in this, where we're talking about fewer restrictions, but more seizures, I don't think those really ever align. And I try to explain that to people, that if you're having frequent breakthrough seizures, it's somewhat unlikely that you're going to be able to have fewer restrictions in general. It's not always the case. But we also want to make sure that those side effects don't cause undue restriction. So it's a balance. I think one thing is communication and allowing people to be decision makers with options, so that if there are 3 medications that we could choose, running through the benefits and the side effects and the downsides of them, and then letting someone choose which one sounds best to them, I think is a good approach. And then in terms of surgery, I think the first time we ever bring up surgery, there's usually a recoil from the person, like, whoa, I haven't heard this. And so the other thing that I think is that although our goals might not seem to line up, they probably do actually. Our goal is to get best quality of life in whatever capacity. So that just takes time, communication, education. And I think that's really our role at almost every visit, is to present the data, present the options, and come up with a treatment decision together. Because ultimately, I think the goals do line up when you're coming to see an epileptologist. It's just how we get there might be a little bit more challenging, and that takes time and communication.
Yeah. Great points. Thank you, Cheri and Dr. Zillgitt. I think from a pediatric side of things, we know parents always want what's best for their children, and that's one of the core and anchoring principles that I think we use when we approach care. And I think if there are differences of approach on how to get there, of course that is also what physicians wanting that too. If there are questions about how to get there, we always want to ask, what is it, if we're maybe disagreeing on the approach vis-a-vis medication versus surgery versus a diet, what is it that keeps somebody from wanting to take that path? What are the specific fears? Is it related to side effects? Is it related to how it's going to affect, just day-to-day life, lifestyle? I find often just by being clear about about those things, we make a lot of progress. Like you were mentioning, Dr. Zillgitt, in terms of medications, and really so many of these treatment choices, offering a series of options, with medications. It's not just one that I'm offering, but there's multiple that we could use that could be helpful. And if we're talking about let's say, dietary approaches to epilepsy, there's a range of diets that we can sometimes think about to help with that. And so understanding that there's always kind of choices to make within the choices, and understanding, I think, what some of the individual's concerns and fears are, in as concrete terms as possible, are the tools that I try to use.
And I think, yeah, just, and I'll stop talking here, because I know I'm talking a lot. Even within surgery, so we talk about medication, we've talked about diet, even within surgery, Cheri, as you pointed out, you've had at least two different types of surgeries that are relatively unique, that are markedly different approaches. And I think even within surgery, it's important to know that this is different than 10, 20 years ago, where it was kind of resection was the way to go, or VNS. There are options for surgery that are there just as similar as diet and to medication. So I think having all of this available allows to make a good decision that I think ultimately the goals align. But having those options, I think, is really important.
And I would definitely agree with that. And as someone with epilepsy, and I have kids, my quality of life directly affects theirs.
Mm-hmm.
Epilepsy came at a time out of nowhere, no reason, no cause, no history. And so it completely disrupted my life. And they were young, they've grown up with it at this point, and they understand, but I didn't want to keep them home in our backyard all the time. We still went out places, to the parks, but we had our safety protocols, our rules, and things like that. But even I've been on a med change, and this gets a little bit personal, over the past few months. We're distance learning, virtual. And so even that has impacted me. I'm overly tired. I don't feel good because of the med change. It becomes a bigger thing. It's not just Tylenol to ibuprofen, which even that's exaggerated a little bit, but it's hard to deal with. So there is that communication, and I do voice that to my doctor that I'm not feeling well. And we work even through that med change. Maybe going a little slower, maybe moving one a little quicker if it's the cause. But that communication, Dr. Zillgitt, is exactly what is needed. If it's not there, then treatment, I don't have the right words for it, but it can be rough.
Right. So medical appointments, with exceptions maybe of new patient visits, are typically quite brief, and there may be a lot of ground to cover in a short period of time. So what do you see as the key patient and clinician related factors that influence the effectiveness of appointments? And then also what helps with kind of retention of information, because there's a lot of ground to be covered in that short period of time, and it's easy to miss important points. So whoever would like to go first can jump right in.
I'll often, Russ, gosh, doesn't it feel true that the time that we spend with one another in clinic just shrinks smaller and smaller? But I will often come in with kind of a top three question type of thing, or ask families what their top questions are just at the beginning, and share mine as well, just so we kind of have a sense of what each other's priorities are for the visit. And to make sure that we can, address those. That's one way. I think you're right in terms of knowing that so much information can be reviewed over the course of a visit, that after that type of overture at the beginning, having a coda, just kind of a recap at the end, going over the kind of the answers, like what's emerged to those most salient questions with families at the end, just to make sure that we go over that data again. And then often summarizing it in an after visit summary can be very helpful, specifically, of course, when it comes to some of the numbers driven stuff like medication doses, changes, numbers to call for appointments, and testing, things like that. Those are some of the tools that I use.
Right. And you mentioned the after visit summary. I just had a doctor's appointment and went into the portal and read the after visit summary. And it was also helpful just to know that, okay, yeah, this is accurate. What I was trying to communicate was actually accurately understood and documented, which I think is important too. So Cheri or Dr. Zillgitt, you want to?
I can go.
Yep.
And I forget plenty of information as we go through. There is always the same nature of appointment that, especially after NeuroPace, it's uploading information. And if you're not familiar with NeuroPace, that's a whole different subject. But what I rely on for after appointments, though, is the provider's notes in my chart. And I read through all of it. It's a very detailed summary of what happened, of my history, and it can get quite long, but it even goes down to, at this point, what specific changes were made to NeuroPace. And those little things I can forget, because there's so many changes that can be done with that thing. But I want to make sure that the appointment, I understand what happened and what we're talking about, especially if there were plans made for the future. My doctor does like to do a plan A, plan B type thing, which I'm grateful. I like that he's open and keeps options going, but I forget them easily. And if I don't understand something, I definitely message back for clarification. For appointments, I've also gone into having any questions that were unanswered through my chart on a document with me, a list of my events that have been recorded with me. I bring all of it because I know that he will want that information. We have a setup of what is of me, and he knows that I will have questions.
Great. Dr. Zillgitt?
Yeah, I would probably just kind of echo everything that's been said. I like that you use the term effectiveness for appointments and maybe not efficiency, because I might be the most inefficient person when it comes to clinic. I apologize to people regularly for running very late, but you're right. I think the schedule allows for only brief return visits, but I think, your initial visit is an education visit. That's how I've always approached it, and then the follow-ups are really outlining the path of how we get to places. So it might be scheduled for 30 minutes or 15 minutes. And I'm not saying this to sound overly altruistic. We'll spend as much time as we need to spend in those follow-up visits. And I know Dr. Shaw does the same. And I know all of our colleagues here do the same as well. So that to have an effective appointment sometimes means to be inefficient, I think, in terms of just timeliness. But, I think what are the key points that I always like to know? I like to know what the seizure frequency is, the medication side effects, and then I think very similar to what Alexa talked about in the after visit summary, and Russ, what you pointed out is a nice detailed description of our plan. And then Cheri, I employ the same things. I was told when I was in fellowship that I should have a plan A, B, and C every time that I approach anything. So we outline what next steps could be, and that's all in the after visit summary. Then we re-review it, and oftentimes we'll do the teach back where, all right, if there's questions, explain to me what you understand. And I think that is again, we go back to just the communication, but I think this is what Dr. Shaw and Cheri have pointed out with what they've said. So I would just echo that. And with electronic medical records, there are so many things that I think frustrate physicians, but I do think some of the benefits from them really are, and the ability for more effective communication with the patient and physician, and that comes through the My Chart, which we've talked about a little bit, and also the after visit summaries, which everyone gets at the end of their visit. So I think the things that we always want to know about are, how's your quality of life? What's the seizure frequency? Let's talk about those. I like to run through some of the AA and quality measures, which also include, women of childbearing age reviewing different medications and specific complications that might be unique to them. We review seizure and epilepsy safety, and then we always screen for things like depression, anxiety. So all of those, I think, are the key components when you're having a follow-up, and then the review through the after visit summary, and the clinic notes, as Cheri pointed out. So I'm just echoing, I think, what everybody already said.
Yeah, the clinic notes came up, and that one was last year. I misunderstood what I was told during the clinic notes said something other than I perceived, and I ended up having a follow-up appointment at. So because it was a surgical monitoring, and there was a flip between another resection or neuropace. It was a toss-up based on recording data during monitoring. But I needed clarification. I didn't want to go into that confused, because it creates even further fear of what may or may not happen. So I like provider notes. The My Health summary, or the summary for my chart, it gives a little bit. Provider notes are much more detailed.
Yeah.
Right, and that kind of leads nicely into our next question about responsibilities, and one of the key responsibilities, I think, of patients and caregivers is to make sure you go in and read those notes, because there may be something that you missed or something that you misunderstood, and then by doing that you can help to cement that information in your memory, and then also have the opportunity to clarify anything that was unclear. Again, the patient and caregivers' responsibilities influence health outcomes, and open and honest communication about those responsibilities is really essential. So what patient and caregiver behaviors do you see as the key drivers of seizure freedom and quality of life, and which behaviors most often get in the way?
Dr. Shaw, do you want to start again?
Give me the tough ones, Dr. Zillgitt. No,
I'll take the next couple.
Certainly we know that for some folks with epilepsy, the effectiveness of treatment plans, or the degree to which reaching seizure freedom might be achievable is related to some personal characteristics or decisions over which we have control. Others, for others, of course, that may not be the case. And so I think we're kind of focusing in on maybe a more limited group of people, but certainly, I think for both providers and patients, trust is probably one of the most important ones. Trusting that the recommendations that have been made are in the patient's best interest, that that we trust in our plan that we make together, that a patient's gonna pursue it. Certainly we want both parties to be organized to the best degree they can. I echo Dr. Zillgitt. I appreciate that I'm maybe not always the most efficient and organized thinker or talker, but definitely making sure that we have a paper trail and the concrete details in something like an AVS, an after visit summary, or recapping together to make sure that we both have the details of the plan in our heads. Those are probably some of the main things.
Yeah, I thank you for answering the hard question first, so I can sound smart and just repeat what you said. I think there's a couple other things that can be beneficial too, that I always say that are in addition to medication, these therapeutic lifestyle modifications. So, we always want to make sure people get appropriate sleep, that they try to limit stress in their life, which I know is impossible to do for the most part. And certainly now in these challenging times, but avoidance of excessive alcohol use. Some of these things I think can be behaviors that are barriers to improve seizure control, that are also living your life. And I think this goes back to some of the things that Cheri was kind of bringing up early is, epilepsy affects the person, but it can affect the family, and you don't want to limit what you can do and how you do things. And so if there's a late night, you don't want to have to worry, oh, did I not get enough sleep? And am I going to have a seizure the next day? But I think those are some of the things that I focus on, in addition to medications that can be a driver for, or medications, diet, or even surgery that can be a driver toward improved quality of life and seizure freedom. But I don't, this is, again, maybe because we're in unique clinics where we deal primarily with people with epilepsy. I don't run into a lot of barriers. Everybody that I see, and maybe again, I'm being naive to this, but I think everybody is on the same page to get to the final goal, which is best quality of life and seizure freedom. So I think I don't encounter a lot of behaviors that really go in the way of that. I think for the most part, that people are motivated to get there. So I don't know, Cheri, what are your thoughts?
Well, let me start.
I'm getting a page. I just have to answer one thing real quick. I apologize. Sorry.
Well,
Hello?
I'll go on. Dr. Zillgitt talks about the trust and, well, no, that was you, Dr. Shaw. Trust, organization, and then the plans from Dr. Zillgitt.
Yeah.
And that is all a part of it. As a person coming into a doctor's office, we don't know what is expected outside of medication necessarily. Even during first appointments, not all of the behaviors, the riskier behaviors that could lead to seizures aren't always spelled out. A lot of that I looked up myself, but as we go through medications, I shouldn't drink a lot of caffeine to offset how tired I am. Caffeine, and there is a balance, but a lot of the interaction with my provider is me wanting further explanation to build that trust in what he's saying. He might say, well, let's try this med. Okay, why? And that's the type of patient that he apparently likes, because I asked him outright recently, what are my benefits, doctor? What do you like about me, and where can we improve? Why are you laughing at me, Dr. Zillgitt?
No, I love that question. I
think that's such a great question, Cheri.
Yeah,
I wish I wish I would love if patients and families asked, what am I doing well?
Well, that was more recently because of the conference, but he and I have built a rapport too. I am honest about my lifestyle. I'm honest about alcohol consumption, what I'm doing, drugs, mental health, whatever the questions come, I'm honest about that because it definitely matters. But we have also, knowing what he is looking for in my own seizure treatment helps a lot. And it gets kind of quirky, but he likes that I'm willing to research about the treatment options, and they drill him with questions. That's just kind of my patient thing. It's not every person has the time or the patience to dig for information, and the resources aren't really given. That's something that I would like doctors to do, not necessarily tell patients you should go research, but if you want further information, where to start researching. And that's another topic that will come up for us, but we don't know starting out. I started out with the foundation. That's the first, when you type in epilepsy, the Epilepsy Foundation is what comes up. And from there, I went off. I have a degree. It's not useful because epilepsy stopped that plan. But I know how to research. It's where and what to research.
Right.
Cheri, you bring up so many good points. I just wanted to mention quickly, I love that, sometimes I think we get pulled into focusing on what isn't going well, because of course we have to talk about things that need to be adjusted if seizures are happening, in medicine and other things. But but there certainly has to be space for talking about what's going right, especially when things are going right, or finding what's going right, even when, other things maybe aren't going as well as we'd want them to. So I love that. I'm hereby adopting that into my clinic practice. So thank you so much for sharing that with me. But I think you also raise a really good point of saying, question asking. I know that Dr. Zillgitt feels the same, but I love as many questions as a patient and family can throw at me. It's one of the things that I appreciate most about clinic, is being able to go over all of those and make sure we just clear the decks before we say goodbye to one another and the visit is over. So that's key as well. Thanks so much.
Yeah,
No,
and
it's
I just
definitely
want to
better
be
in,
clear.
oh, sorry.
No, go ahead. Sorry.
It's definitely better in person asking questions, because some of my questions I can get long-winded, and I don't necessarily expect those to be answered through the MyChart portals at that point. There are other patients that need their questions answered versus me asking. Sometimes it's random, but applies to my case. So it's not something, it's not about zebras in Africa. No, false. But I can get lengthy with the questions, and it's better in person, Dr. Shaw, to get it all out. But that is why I come to appointments with a list of questions.
Yeah, and I just want to be clear. I was smiling. I thought what you were asking was a great question to ask. This was not laughing at you. This was just being, that's a great question to ask. And I think I'm going to steal that as well. So we will. I will give you credit here. I won't share your name, obviously, in future visits, but I think that's a great question and thing to incorporate into clinic visits. So,
why are you laughing at me, or what?
No, I'm not laughing at you. I think I know. I don't mean it.
That was sarcasm. I'm not offended. This is how I roll, Dr. Zillgitt, and Russ is laughing. I see that one. So I get laughed at, and that's the nature of me, and my doctors, they laugh at me.
No, that sounds like you have a great relationship with your physician, so that's great.
So Cheri, you were talking about doing research, and that leads right into our next topic, which is that there's a spectrum when it comes to medical decision making, with some patients preferring to let the physician make what they feel is the best decision for them, and others really taking the lead role in decision making and having the physician play more of an advisory role. So over the years, though, I think patients and families have generally moved towards playing a more active role in decision making. So can each of you talk about a few decisions related to epilepsy care that are particularly common or challenging, and give some examples of how effective partnership led to effective decisions?
I can start with this one because I think this one's hard too. I think all of these questions are great questions. I think from some of the challenges that come in are things that we've talked about so far, and I think that Cheri's articulated very nicely, that any treatment that we're going to offer has the potential to have great benefit, but also maybe side effects, and it's balancing that and having that communication. And I think that sometimes by the time you get to an epilepsy center, you see an epileptologist, you've been through so much, to hear some of these things again or in a different way, or now I have to do more. I think that's a challenge, and I think there can be this level of frustration that comes with that. I think on a personal level, where I experience that the most is where people are not doing well with medications. They're still having seizures. Quality of life is poor, and then we open up the discussion for surgery. That tends to be something that, again, is not something they've heard before, and it leads to unease to hear somebody talk about brain surgery, maybe even within the first hour that you've met them. So I think it goes back to communication, presenting options within options, and developing those plans A, B, C, and D for how you want to move forward. And then from an education perspective, what other resources are available. I do think, and we make sure we have this on and I know other centers do this as well, so this isn't unique to Beaumont. I think every center makes sure that the contact information for the Epilepsy Foundation is included on that after visit summary, because this is a great resource, a great touching point to then branch off into even more more detailed resources. So in terms of resources that I think are helpful, the Epilepsy Foundation, obviously, but epilepsy.com, which is the Epilepsy Foundation of America, has some very nice resources. Up to Date, I think, has a patient version of topics that are available, and if you want to even get onto the physician portals or of Up to Date, you can do that as well. So I think those are some great resources, and ultimately I think when you're sitting with an epileptologist, hammering them with questions, just as Cheri talked about, and just as Dr. Shaw and it loves to do, or answer those questions, and I do as well. You're with somebody who's done extra training specifically in epilepsy. We can be a great resource and provide some other resources outside of the visit, but we can be your resource for a lot of the questions you have.
Dr. Shaw?
Yeah, Dr. Zillgitt, those are all excellent points. I would echo each, and instead of repeating them, would only share in the pediatric epilepsy world. Specifically, there can be so many rare entities, rare disease entities causing seizures. It's been so moving and so amazing to me to see the outcropping of individual sites, primarily run by families and sometimes with allies in the physician community, dedicated to amassing whatever the current and contemporary research and treatment options are for some rare genetic, metabolic, other types of disorders. And so I'll often tell families, chances are you might be an expert in this, more than me, depending on what the cause of somebody's epilepsy might be. And I always welcome families, doing research on their own, especially, reading, finding some of these websites and reading the collected wisdom from scientific journals and other family experiences and other physicians, and bringing them to me because they're more than I can individually kind of keep track of. So that's just one other side from the pediatric world.
Yeah. And I research and I ask questions too, but I do trust my doctor at this point. I with those questions and the research I definitely play an active role in decision making. I'm not afraid to say no if I'm completely uncomfortable with it all, but I still have gone through the surgical processes, even though they scared me out of, I don't want to say to death, I hate that, but so fine, I said it scared me to death. But that's why I ask those questions, so I can have that trust with providers. There have been situations with previous providers where there was no communication. There was no allowing me to even express my opinion about their plan of action. It was either you do this or nothing. I'm not with those providers. So there has to be a balance.
Right. And,
Yeah.
and go ahead.
Oh, so that just, again, echoing what Dr. Shaw had said about the websites. I think the American Epilepsy Society website has a link for patient resources. And there are, I think, at least at last count, 30 or 40 specific advocacy groups. The Citizens United, again, for treatment of epilepsy, or CURE, I think is the name of it, is a website.
They just changed their name to Cure Epilepsy. That's the,
Yeah. And so I think those resources go back, and just as Dr. Shaw pointed out, sometimes people come in with information that I hadn't even seen yet. And I think, wow, that this is good stuff. So yeah, the Epilepsy Foundation and American Epilepsy Society and the Epilepsy Foundation of Michigan are all, I think, jumping points for further research outside of maybe what you get from the physician.
Those are, in my smart phrase, added to every after visit summary for every new patient that's diagnosed with epilepsy.
then I'm going to steal your smart phrase.
Yeah.
Right, and I definitely, just to add on to that, encourage people to really dive into our website and epilepsy.com. For a great way to do that on our website is to go to our YouTube channel, because we have recordings of all conference presentations like this and our Learn and Share conference calls. We have close to 100 different recordings on virtually every topic you can imagine, and they're all in depth. So they go to a much deeper level than you might get in a quick summary on a web page. So, we try to explore things from all different angles. So definitely check those out when you get a chance if you're trying to make a difficult decision. One thing I wanted to follow up on what Cheri said about one of her previous providers not listening. And that sometimes is the case particularly with drug-resistant epilepsy, that patients and caregivers might reach a point where they begin to consider switching providers or seeking a second opinion. In some cases, the physician might even recommend this. What are some of the circumstances under which a second opinion or provider switch might be warranted? And are there any downsides to seeking one?
I think this is, Dr. Shah, this is a challenging question, I think, for us to answer. Oftentimes when you get to an epilepsy center, we are the second opinion. So seeking another opinion outside of us, at no point do we ever restrict people or not want other people to get more opinions. I think that's important. And it's always important to find a provider that you connect with, and that you can be active in the decision making. As Cheri pointed out, there are some physicians who will come in and say, you're going to try this medication, and then leave, and you say, whoa, that's not what I want. And so I think finding the physician that works best for you is very important. What's beautiful in this state, there are great epilepsy centers across the entire state, from Grand Rapids with Spectrum, St. Mary's, to Metro Detroit with U of M, Henry Ford, DMC, Beaumont, obviously. I think we do a good job, and even Michigan State University. So you have access to a lot of epilepsy centers, and the potential to get very good second opinions, or third opinions, depending on how you feel with the way things are going. I think one of the challenges with this or downside is that if there's not open communication with that, if someone came to say, hey, I want a second opinion, I say, okay, cool. Where do you want to go? Who would you like to see? Who do you think would be better for you? And then we can maybe make that decision together. I've had situations where people have gone for a second opinion or a third opinion, unbeknownst to me, and come back with markedly different treatment decisions that I don't think we would have gone down. And in some ways, I don't think it improved care. And then they're back to say, where do we go now? And now we've taken a couple steps back. So I think that there really isn't a downside. I don't think there's a downside to a second opinion, but I think having an open line of communication about where to go and how to approach that is important. And oftentimes, as the epileptologist, we've become the second or third opinion in that situation. So going from us to another epileptologist is fine, and certainly, warranted. And I think we all encourage that if that's what people want to do, but I think there just needs to be communication with that.
And that is where it comes down to. I saw a neurologist, general neurologist first, and the questions I was asking, because even at that point, I was new to epilepsy, and I'm an info fiend. I just go after it. So I had questions that they just couldn't answer. And then I went to an epileptologist. I asked for referral after one appointment with general neuro. And that epileptologist is the one who gave me no deciding influence on my treatment. And it was I don't quite want to get into it. It was a brutal experience. That wasn't over medication, but so I went to a second epileptologist, and that's where I found we clicked. We worked together. We communicated. It was a better experience overall. The problem with switching is as a patient, you feel like you're starting all over. And even as doctors, you're coming in with new patients and you need all of their new information if they don't have it. Well, you need all their information, but someone told me to think of it as going like you're going out for a date with someone you haven't met yet. And fair advice, but I don't want to date my doctor. That's weird. But it can be awkward to go in to someone new you have never met in a new office, new health system. It's odd.
Dr. Shaw, any thoughts on that?
Yeah, again, I would echo everything Dr. Zillgitt and Cheri have mentioned already. The short answer being, if a family or a patient would like a second opinion, I think every physician who's currently taking care of them should be open to it. That's a decision that it's well within any patient and family's rights to request. And it's something, if anything, I, for instance, would love to be able to support as best I can and just help out, making sure that if you are going to see a second opinion, it's from somebody who, again, is part of a comprehensive epilepsy center, like Dr. Zillgitt said, that we can get records, like clinic notes and EEG results and other data together. So they don't have to be repeated, let's say, at another center, so that the package of information is most helpful for that other physician who might be reviewing it. And then the only other thing I wanted to mention, I guess, is just to make sure, and I know, Russ, we've talked about this at other Epilepsy Foundation conferences, just to make sure at some point, if your child or if you as an adult have epilepsy, that you're actually seeing an epileptologist, at least once. I advocate for that to make sure that you've got the correct classification of epilepsy, that you've been offered the right therapeutic options. So just to make sure that if you're seeing a general neurologist, currently, if a child has epilepsy, think about seeking out the opinion of an epileptologist at some point.
Okay. Great. One more question before we move on to the Q&A portion. It looks like we only have one question at this point, but it's not uncommon for people with epilepsy and family members to have an interest in complementary therapies. And that can sometimes be a point of contention between patients and physicians. Can each of you share your general philosophy about complementary therapies and how you discuss this issue when it comes up?
It's a great question, Russ. I can go first. My speaking in very broad strokes, my general approach is I want patients to receive care that's that has the most data to suggest that it'll be effective and safe. And so my initial goals are to use the compounds or the therapies and approaches that will achieve those goals. That said, if there are therapies or interventions or approaches that a family wishes to pursue, outside of those options, I always want to make sure that that there is a kind of a budget question and a safety question being addressed. The safety question probably, well, they're both very important. Making sure that I can look at the intended compound or a therapy and go over with a family what I think of the safety of that approach might be, specifically how it might interact with the medications or diet or anything that we're using. And then, of course, to make sure that it's within a patient's budget and to understand that, unfortunately, I think Dr. Zillgitt may feel similarly. We start to feel a little protective over the years and maybe even sometimes a little cynical, just seeing how, very sadly, some families have been really taken advantage of financially by people suggesting treatments that have, encouraged parents to dip into their retirement savings and things like that. And, that's just something that makes me feel very protective and, want to help out with.
That's a great point. Cheri or Dr. Zillgitt?
I don't have much experience with um, oh, complementary therapies. Friends and friends of friends have suggested some interesting things to me, but I have no basis in, well, I don't feel that those treatments have basis in neurology and can become dangerous even to a point. So I just let it go. I haven't had issue with with it coming up, but the things that people will suggest are, spices, essential oils, psychedelic mushrooms has been suggested by friends of friends, and also an exorcism. So those I just, no, not for me.
Yeah, I can speak for the Epilepsy Foundation of Michigan, is that we do not recommend exorcisms as a treatment for epilepsy. Oh dear.
Yeah. There's a really, if you're interested in the history of medical conditions, and there's a relatively dense and sometimes challenging to read book called The Falling Sickness. And I believe exorcism was used at some point to treat epilepsy, and not surprisingly ineffectively. So yeah, I think across the board, if there's one thing we could agree on, that's probably not a complementary approach. I think one of the early complementary approaches that came up fairly regularly was the use of cannabidiol. And over time, that's actually shifted into an efficacious treatment for many people. When it first started, though, and people were asking about it, the dosing wasn't quite clear. Consistent strains of cannabidiol from the dispensaries were not clear, and so I think there was some challenges with how to use that. But I think in some situations, some complementary therapies, and I think cannabidiol is one of them, have become, I think, an efficacious treatment. And now there's even an FDA approved medication and Epidiolex that is. And I think that kind of came out of maybe a quote unquote complementary approach. And although Dr. Shaw, it can talk for hours on diet therapy, I think at one point diet therapy was thought to be a complementary approach that has merged into a relative standard of care for people with epilepsy. So some of these complementary approaches are what are considered complementary approaches actually move into the mainstream for our treatments. But I would just reiterate what everyone else has said, that I don't think it's something that we approach very regularly or recommend unless there's good evidence for that. The cost, as Dr. Shaw pointed out, can be substantial, and it's unfortunate when when people encounter that. And safety, especially with the quote unquote nutraceuticals, they don't fall under the FDA regulations. So they don't have to go through the rigorous trials and standardization that a medication or even a therapy like surgery would have to. And so consistency of what you're taking, efficacy of what you're taking has not been studied in the same rigorous ways that other treatments have. So when people ask about this, I don't have a lot of great insight into it, because I personally, I try to steer us into areas where we do know there's good efficacy and safety. But to that end, I'm also open to these things, because if we look at cannabidiol and even diet therapy to some degree, although I think diet therapy, if you really look at the data all along, should have never been thought of as a complementary approach, but I think at some point it may have been. These things do get incorporated, and so I think having an open mind as well is important, but data will drive those decisions.
Okay, so but we have run out of time, unfortunately, and there's one question that I think can be answered quickly, so I'm going to address that now that someone had submitted. How are you handling allowing caregivers at appointments for during the pandemic?
In the hospital, there's different restrictions than there are in the clinic. So specifically in the clinic, we allow a visitor, one visitor. If there's special needs, there's sometimes two visitors, but typically only one.
Yeah, in the pediatrics clinic, both parents are allowed to come to the in-person clinic visits.
Okay.
Same thing for hospital stays right now.
Okay. And one more quick question for you, Cheri. Are you aware of any forums where patients with the RNS can communicate with each other?
I'm not actually, and that's difficult. I would like to see something like that. There currently are only just over 2,800 people with RNS, which, okay, that sounds like quite a lot, but it's hard to find people to connect with.
Mhm.
And I could reach out to NeuroPace.
Yeah, in fact, if we
ask
have
them
anyone
if they
from
have one.
NeuroPace on the call or on the Zoom webinar, if you wanted to add in or in the chat box, if you're aware of any such resources through NeuroPace, that would be helpful. And of course, we have our Call and Connect program, which would be, I know we have other people who use the NeuroPace who have participated in that, so that would be another option. So, all right, so thank you so much for a great conversation, and we're going to move on to our next one. So thanks again, Cheri, Dr. Zillgitt, and Dr. Shaw for an excellent discussion. So our next question or session is Medications Open Forum, and we are pleased to have with us today Dr. Ayman Haykal, who is an epileptologist from Spectrum Health, Dr. Iqbal Allarakhia, who's a pediatric epileptologist from Ascension, Maggie Faraj, who is a pharmacist from CAZMA and Blue Cross Blue Shield of Michigan, and Jenn Brown, who's a parent of a young adult with epilepsy, will be sharing her personal perspective. So this session will consist entirely of questions and answers. So please submit your questions using the Q&A feature. And we'd like to address as many questions as possible, so please keep them brief and avoid including extensive background information. This is not a forum for soliciting specific medical advice. The panelists do not have access to your medical records, so they cannot provide specific medical advice. And in the interest of time and clarity, I may rephrase or shorten certain questions or combine multiple questions that relate to the same issue. So while the focus of this session will be on anti-seizure medications, please feel free to ask about medications for conditions commonly associated with epilepsy, things like depression or ADHD or things like that. So to give our audience a better idea of each panelist's expertise, can each of you briefly introduce yourself and your experience with this topic? Dr. Haykal, if you could unmute yourself and give a brief introduction, that'd be great.
Ross, thank you for having me today. So my name is Ayman Haykal. I'm a neurologist, epileptologist at Spectrum Health. Been in practice for 8 years now. So I treat adults. My interest is in treatment of drug-resistant or medically refractory epilepsy. Both medical treatment and surgical treatment or neuromodulation.
Okay, great. Dr. Allarakhia?
Yeah, I'm a pediatric neurologist with training in clinical neurophysiology and epilepsy. I work at Ascension Health at the main campus in Detroit. I also provide coverage for reading EEGs at the other Ascension sites as well.
Okay.
And I've been in practice for more than 20 years.
Great. Maggie? Oh, you're muted. Sorry.
Sorry. Thank you, Ross. So I got my Doctor of Pharmacy degree from Wayne State in 2018. I did a 1-year residency at the Detroit Medical Center, and it was a general residency, but then I did a 2nd-year residency in ambulatory care, and that's when I was staffing an epilepsy clinic at the DMC for the geriatric patient population. And I'm currently a clinical pharmacist at Blue Cross Blue Shield.
Great. And I think that's a really important point, is that medication issues, particularly when it comes to epilepsy, can be have a lot more nuance and complications when it comes to older adults. So right. That's a great experience to share. Jenn, can you introduce yourself?
Yep. Thank you for the opportunity to share our family's epilepsy prescription journey with all of you. On April 30th of 2014, our world came to an abrupt halt when our daughter, who was 12 at the time, had her first tonic-clonic seizure. It was a major pause in our lives as we tried to wrap our minds around what was going on and what was the cause and what we needed to do to prevent the next seizure. And at the ER and after an MRI that showed nothing, which we later found out was a misread MRI, the doctors said it was a one and done, don't worry about it, that many people have seizures. But 2 weeks to the day of her first seizure and the same day as her first appointment with the neurologist, she had her second tonic-clonic seizure. And that became the new diagnosis of epilepsy and began the journey and our quest to find the right prescriptions to keep the seizures at bay.
Okay, thank you. All right, so let's dive right in. And we have some questions lined up already. So, and I encourage people to keep submitting them. To the providers, how do you understand the role of depression and anxiety in the lives of people with epilepsy? How do you address this, particularly when medications are needed for both conditions? Do you prescribe the antidepressant meds yourself or recommend a patient see his or her PCP or a psychiatrist? It's been my experience that depression resulting from the impact of epilepsy implications for date, so it kind of trails off there, but let's see. That sometimes the depression resulting from the impact of epilepsy can sometimes counter the positive effects of having a diagnosis, meds, or later surgery. So can you just talk about, I guess, the role of medications in treating depression versus, there's the issue of some medications, some anti-seizure medications themselves can be mood stabilizers, and some can exacerbate depression. So can just someone talk about some of the key decisions that relate to medications as it relates to depression and anxiety?
I think it's important to figure out whether the depression or the anxiety was coexisting or pre-existing prior to the treatment with a seizure medication. It's a very complex issue because whatever leads a person to have epilepsy or recurrent seizures can also predispose them to having anxieties and also depression. So you can have what we call comorbidities where two conditions can coexist. But it's also important to recognize that some medications can predispose people to having worsened moods and irritability and enhance the anxiety. So it's important to try and sort out if it was pre-existing or not. It's also important to avoid in persons who are predisposed to depression or who already have some symptoms of it, to avoid medications which can make things worse overall. There are some medications like, for example, the levetiracetam or Keppra, about 10% likelihood of causing irritability or depression. So you have to keep all those things in mind. When a person with epilepsy has coexisting or worsened depressive symptoms, if they are milder, I tend to treat them myself, but I generally recommend that they see a therapist first. If clearly if the symptoms are severe and they need urgent care, urgent attention, I refer them quickly to a psychiatrist.
Okay.
Yeah.
Go ahead.
I'll add, I agree with Dr. Allarakhia. We have to remember that a lot of patients with epilepsy experience depression and anxiety, and we always use the metaphor of the epilepsy iceberg, and we see at the tip of that, seizures are as the main symptom of epilepsy, and that is true. But underneath the water, there's depression, anxiety, the effects of epilepsy on the patient's independence, the side effects of medications, etc. Depression is very, very common in patients with medically refractory epilepsy or drug-resistant epilepsy. And I just want to add that it is, in a lot of patients, it is important to treat depression with antidepressants. And in the vast majority of cases, it is safe to do so. So the majority of antidepressants are safe in patients with epilepsy. There are a minority of medications that might lower the seizure threshold. These should not be used as first-line treatment, for example, bupropion or Wellbutrin and tricyclic antidepressants. But most antidepressants are safe, and it is important to treat the depression. We see sometimes there's actually some research showing that patients with untreated depression might not do really well in terms of seizure control as well. So it's very, very important to address that symptom. In certain mild cases, medications that are mood stabilizers, like you mentioned, Russ, can be helpful, like lamotrigine or valproate. But in my experience, for a lot of patients with drug-resistant epilepsy, a dedicated antidepressant is needed.
Okay. Any other thoughts on this topic? Okay.
I would just like to echo what has already been said. A lot of times we see depression, bipolar. These comorbid conditions either push us away from certain medications or actually would prompt us to add specific medications that will help with comorbid conditions. Migraine was also a common comorbid condition that we would see patients have, and that would, for example, prompt us to add topiramate, for example. If someone has a history of aggression or unstable mood, then we would think twice about adding levetiracetam or Keppra.
Okay, great. So a question about catamenial epilepsy or seizures that appeared at certain times of the menstrual cycle. Can you talk about any medication-related strategies that can address catamenial epilepsy?
So I guess I'll answer that, since you see this, more commonly maybe in adults. There are different strategies that can be used. Catamenial epilepsy is very common and probably under-recognized in women with epilepsy. But basically, we think of the two sex hormones, estrogen and progesterone, as having different effects on the seizure threshold. And in general, putting it in a very simplistic way, estrogen promotes seizures or encourages seizures, and progesterone does the opposite. So when you have a higher ratio of estrogen to progesterone in a majority of cases of catamenial epilepsy is when you are more prone to seizures. So one of the strategies is to, once you identify a catamenial pattern for seizures, is to increase medication. The week the patient is expected to be more prone to seizures, or possibly add another medication. Sometimes we use a benzodiazepine like clonazepam for that. There is some old data showing that an anti-epileptic medication called acetazolamide can be effective in catamenial epilepsy. In my personal experience, I haven't had great success with that approach. And then sometimes what you can do is use progesterone-based hormonal therapy or contraception to basically, again, because progesterone is a hormone that increases the seizure thresholds, or in a way protects against seizures. So have the patient, use that as long as there's no contraindication. Try that. I've seen some success with this approach in my experience, but what I most often start with is maybe a supplemental and additional medication for the 1 week or so, or the few days when the seizures are expected to increase.
And am I correct in my assessment, or for what I've gathered from what I've read, is that there's not a real strong evidence base as to practice guidelines when it comes to this? We're still kind of figuring it out.
Unfortunately, there are no guidelines, and what we know is also does not come. So the approaches I mentioned have not been evaluated in clinical trials that produce strong or reliable evidence. So it's mostly a case series and anecdotal experience.
Yeah. So that anyone wants to write to the NIH and suggest research, this would be a good area for research. Dr.
Definitely.
Allarakhia or any other panelists want to add to this?
You know, the hormonal therapy held promise on a theoretical basis many years ago, but it hasn't, like Dr. Haykal said, that it's not been very fruitful. You know, you'd think that if you had a hormone-based therapy which use progesterone and you know increase the seizure threshold, but unfortunately it didn't work out. The most commonly used option these days is just using a benzodiazepine, as mentioned. That's probably the most practical one.
Jen, was that ever an issue that you encountered with your daughter?
No, it was never.
Okay.
There was never a connection between the two.
Okay.
We never addressed that.
Great. Great. So another question, someone wanted to learn more about Xcopri or cenobamate, which is one of the most recent anti-seizure medications to be FDA approved. Since it's approved in adults, Dr. Haykal, did you want to start with this? Just give a quick overview of what we know about it.
Yeah, so this is probably the newest anti-seizure medication on the market. The data from the clinical trial is encouraging in terms of the efficacy and the rate of seizure reduction and the percentage of patients who can become seizure-free on it. It's a medication that has a very long half-life. So when it started, it needs to be increased very slowly. In terms of side effects, it's generally well tolerated by most patients. One potential drug interaction to be aware of is the interaction with clobazam. And that's a medication a lot of patients with drug-resistant or medically refractory epilepsy are on. So something to be aware of. But in terms of mechanism of action, slightly different than what we already have. Similar in ways, a little bit different in other ways. So it's one additional medication to have in our armamentarium. I haven't used it. I've used it in a few patients, a limited number of patients. So I cannot say I've had a lot of experience with it yet because it's a new medication. But what we see from the clinical trial is promising.
Okay. Anyone else want to add anything to that?
Yeah, I personally, we haven't used it yet. I think it was approved in 2019, if I'm not mistaken. So we've never actually got to use it in any of our patients.
Right, but yeah, as Dr. Haykal said, the clinical trial results are certainly promising. So hopefully over the coming years, we'll know more from direct clinical experience with that. Okay, so another question. Oh, sorry.
It does seem to have some interactions with certain drugs, like if you have someone on phenytoin, so you have to keep that in mind when you start prescribing it.
Okay, great. So another question, my psychiatrist wants to discuss the possibilities of taking psychostimulants for my ADHD, but has mentioned that it lowers the seizure threshold. I had childhood epilepsy, but haven't had seizures for several years. Should I be concerned about taking meds that lower the seizure threshold now, or would I be in the clear? So I'm pretty sure that stimulant medications for ADHD can be safely used. Is that correct in people with epilepsy?
Yeah, stimulants are no longer contraindicated in the presence of epilepsy or even a past history of seizures, and can safely be prescribed. In fact, people who have epilepsy are somewhat more likely to have a coexisting ADHD, and it's important to treat the ADHD if it's causing impairment in learning at school.
Other thoughts on that?
Yeah, we get this question frequently from psychiatrists, sometimes with primary care providers. I think it's based on old data suggesting that stimulants can lower the seizure threshold and are contraindicated in patients with epilepsy. But this is not true in the vast majority of cases. So in my experience, I actually haven't seen any issues when patients taking stimulants and being treated for epilepsy at the same time.
Okay.
I would share that Aubrey has had Focalin as her ADHD medication. And we found that, yeah, it was a little bit scary at the beginning because we didn't know how it would interact with the current prescription she has for her anti-epileptic medication. But we found it necessary in order to help her to be able to focus in school. So we had to take the risk and try it. And it has been a lifesaver for her and able to sit down and be able to study and focus. And she is successful, excuse me, in as a freshman Saginaw Valley State University student. So we know that it was the right decision, but at the time it was a scary decision to try to make.
Right, right. And I think it's also important for adults with epilepsy because sort of similar to autism in that it's often thought of as a childhood disorder and but children grow up to be adults, and a lot of times, and there's also cases of adults who never were diagnosed as a child with ADHD. It was kind of before it was a thing, really. If an adult is noticing that they're having difficulties with cognitive function, a lot of times there's a kind of knee-jerk reaction to assume that it's memory, but it may actually be attention related instead of just memory. So that's certainly a conversation you can have with your epileptologist or neurologist if you're having some difficulties with focusing or attention. Okay, a similar related question to that is often there is kind of that triad of depression, anxiety, and ADHD that all kind of go together. Is there a particular medication that or medications that might work well for those three symptoms or those three conditions when they're combined?
Unfortunately, there isn't a single medication which can help treat all the three at the same time. So usually it ends up being that you have to use a combination of at least two medications. And clearly, if you are treating coexisting or comorbid epilepsy, you have to try and choose something which will not cloud the issue or make attention issues worse. For example, in a young child who is being treated with phenobarb, they're almost always going to have attention issues. So there are some things which have to be avoided in such a situation.
Other thoughts?
And certain medications might be preferred. Again, I agree there's no medication that will treat these three problems, like one for all three. But one of in my practice, a first-line medication would be lamotrigine, unlikely to have cognitive side effects and has the advantage of potential positive effect on mood or mood stabilization. But I don't think that will improve, ADHD symptoms. So, probably if we're talking about pharmacological treatment, you will need more than one medication to address these symptoms.
Okay. Another question was related to someone is currently in college and has been successfully treated on Keppra, is considering weaning off Keppra and pursuing CBD. And we'll be talking with a neurologist soon about that, and is asking if that seems like a reasonable plan. Of course, we can't, without knowing more about the situation, we can't give reasonable advice, but just to kind of generalize that question, sometimes there may be someone who is successfully controlled on a anti-seizure medication may want to try something that they maybe perceive would have fewer side effects. So there's obviously risks in doing that, but any thoughts on that type of decision and how you might go about making that decision?
So first of all, it's important to recognize that that a CBD has been approved and that's a pharmacological grade CBD, which is Epidiolex, the trade name. has been approved for only 3 types of seizures. One is it was first approved for use with Dravet syndrome, and then subsequent to that, it was approved by FDA to treat Lennox-Gastaut syndrome, and more recently, it's been approved to treat patients with focal epilepsy who have tuberous sclerosis syndrome. So it's been specifically approved for just those 3 conditions, and it's very difficult to extrapolate that to, artisanal CBD, which can have varying degrees of efficacy or potency, because it's not well regulated. So we have no evidence whether or not CBD oil has any effectiveness in treating other types of seizures. We may well find out with time that it does, but at this point it's very difficult, or it's impossible to make any recommendations on someone who is in college who has seizures. Clearly, there are many things, like you said. We don't know how long he's been seizure-free. Are there other things he's concerned about? So you have to consider other things as well.
Okay.
I agree. We should look at CBD as just another medication option and evaluate it like we evaluate switching to any other medication. So first, look at the evidence. Does it work for that particular seizure type or not? Is there evidence to support its use? And then, I agree that there's not a lot of data on using CBD as monotherapy, meaning the only medication in patients with the most common type of epilepsy, which is focal epilepsy. And it might be, it is probably effective, it just hasn't been studied this way. There's misconception, a lot of people think that CBD is a natural treatment and therefore it is side effect free. So, I try, when I talk to patients, we usually talk about this in the media. It's portrayed as the miracle drug that is side effect free and works for everybody and makes everybody seizure free. And this is not true. I mean, like any other medication, even when we're talking about, conditions, seizure types that CBD or Epidiolex was approved for, sometimes it works, sometimes it doesn't. And it does have potential side effects. And there are potential drug-drug interactions as well. So if we decide to use CBD, we have to look at this evidence and then use the pharmaceutical grade CBD, because there are a lot of issues with artisanal CBD, or basically over-the-counter CBD, if you may, that you can buy online, because it is not regulated. Anybody can make anything in a way and label it the way they want. And there was actually one study looking at these artisanal CBD compounds, and that study showed that a majority of them were mislabeled. So those was not very accurate, was not pure CBD. So these are factors to consider. Again, not be influenced by the media buzz about CBD being the miracle medication or a natural treatment that is free of side effects. We have to treat it like any other medication, look at pros and cons before making such a decision. And if we use it, it has to be the, I recommend using the pharmaceutical grade CBD, which is currently only available as Epidiolex.
Right. And if the person is already well controlled on Keppra, they're probably not going to get insurance coverage for Epidiolex. And then the other thing to consider too, if you've been well controlled on Keppra for several years, would be the idea of possibly having a conversation about weaning off medication entirely if your epilepsy type and your EEG and other factors support that. So, okay, another question about the new rescue therapies that have come out, Nasalam and Valtoco, and the intranasal formulations, and what your opinions are on when they should be prescribed, and how aggressively they should be used for seizure clusters or absence seizures.
So Nasalam is a trade name for intranasal Versed or midazolam, and Valtoco is the brand name for the intranasal Valium or diazepam, and they've been approved for treating prolonged seizures and for cluster seizures. And I think it's a very useful addition to our armamentarium of things you can utilize to shorten seizures or to, I think it gives parents an added level of security, when they have a child who or a family member who has epilepsy and is prone to having recurrent or clusters of seizures. It's quite safe to use by caregivers, even when teachers and bus drivers and daycare providers. So it's a quite a good option we have.
Yeah, until recently, we only had the only FDA approved rescue treatment was Diastat, which is given rectally, and obviously it's not a very convenient method of delivering rescue therapy, and at least in the adult population, most patients would not use that. So having these two options, Valtoco and Nasalam, intranasal medications, I think is a very positive development, and may in a lot of patients avoid an ER visit. A lot of times you just get to the ER to get that rescue medicine, and then you basically spend hours in the ER, and you get that ER bill, of course, and all you get in the ER is a rescue medicine. So if we can deliver that at home, keep patients safe, and provide convenient and timely treatment, then I think this is a great development that we have these two options.
And because of that, the route of administration being more acceptable or convenient, do you have you already seen more interest in having this among adults, or have you been prescribing rescue medications more for adults, just as an added sense of security and just again, like you said, to avoid unnecessary ER visits?
Absolutely, and it's it's in my experience, most adults would not use Diastat, so it's rare that I recommend it. I think it's only in cases where patients have really severe seizures, and we conclude that this is the best treatment, rescue treatment for them. But even when I sometimes convince a patient and prescribe it, they don't take it, they don't use it. So yeah, I've been prescribing the intranasal midazolam and diazepam, and patients are much more agreeable to using a nasal spray than rectal medication.
Jen, did your daughter ever have to use a rescue medication, and how did you make those decisions as to which?
An effective rescue medication for her was midazolam, but being sent home with the little vials and the syringes, and then trying to draw them up when there's a seizure and trying to keep yourself together was very taxing. So we were watching, I believe it was first approved in Europe, the Nasalam. So we were watching it, so it was coming across, and we were constantly in contact with our epileptologist to know when it was going to be here. So I'm very thankful that we have it. We haven't had to use it yet, but as one of the doctors had mentioned too, that it's much more easier to give that to a teacher or a bus driver and say, here, can you please use this in the event of a seizure, rather than some of those other options, like the diazepam, diazostat. That's just unreasonable to think that a teacher or a bus driver is going to be able to always use that and use it correctly. So I'm very thankful that there's an option.
Great. So quick question for Dr. Allarakhia, because you'd mentioned phenobarb and attention problems. Are the attention problems with phenobarbital likely to stick with kids into adulthood?
So in most cases, we don't continue phenobarb into adulthood. I mean, there are rare cases when nothing else works and phenobarb works very well, and then you have to make the decision whether or not to, to balance the side effects. The hyperactivity is most often seen in toddlers. So generally you don't see it in older age group, but clearly phenobarb has cognitive and mood side effects. And there was a study done in New England Journal many years ago, which looked at a drop in IQ points by about 7. If a child was on phenobarb and they had been on, and the IQ, there was a documented IQ score drop, which persisted even after the phenobarbital was discontinued. So there are some cognitive and mood side effects, and clearly it's a medicine which should be avoided in older kids and adults. Sometimes you don't have a choice, it's the only thing which works, and you continue it. But
Right. So a question, and maybe Maggie, you might be a good person to answer this one. The question, the person is in their 70s and has been just diagnosed in the last 3 years. So this is adult onset epilepsy, and they're on Keppra and have good with focal seizures and good control, but the side effects are irritation and fatigue. So we know that Keppra is nice for older adults just because it has no interactions. It's got very predictable pharmacokinetics and all of that. So there's a lot of advantages to it. Are there other options if the irritation and fatigue are becoming too much of a problem for older adults?
Right. So in general, we try to avoid the first generation AEDs. So we avoid like phenobarb, phenytoin, just because, like you said, there's a lot of drug interactions, complex pharmacokinetic profiles. We also don't prescribe the third generation right away. They're usually reserved for patients who have like refractory AEDs. So we stick to the second generation AEDs, and I would say Keppra or levetiracetam is a very common option, but there's a lot of options in that category. Like if you think about lamotrigine, topiramate, lacosamide, those are all good options. You just have to look at the side effect profile. And I would say if I would need more information about is the Keppra now intervening with them doing their day-to-day activities, because then when it is that the case, then you want to switch to another AEDs. And like I said, I would say like lamotrigine, topiramate, lacosamide, perampanel. Those are good options for someone in that specific scenario. As long as in older adults, we try to avoid the first generation AEDs because they're worried about osteoporosis, osteomyelitis, and other adverse effects. But if the Keppra is interfering with their day-to-day activities, so maybe we can wean off and add one of those other options.
Okay, great. And there's the same person asked for clarification on first generation versus second versus third generation. I know there'd be a challenge to list off all of them in each category, but basically that correlates with when they were released. So
yeah.
Older medications are first generation, that kind of the ones that were released in the 90s and 2000s roughly are second generation, and then the most recent ones in the last 5 years or so, I would say, are third generation.
Yeah, like starting 1900s up to like the early 1990s, that was first generation. Second generation can go up to I think like 2000, and that's carbazepine, and then starting from there, you're looking at the third generation AEDs. So the first generations, they're still good in controlling seizures, but that complex pharmacokinetic profile, the drug-drug interactions and adverse effects, we try to avoid them.
Right. And I think that's an important point just to bring up, is that over all of this time, we haven't really seen a significant increase in efficacy. We've seen improvements in terms of fewer interactions and maybe better side effect profiles, but efficacy hasn't really improved that much. Is that right?
I would want to say yes. And I think in neurology, particularly AEDs, there's a lack of head-to-head trials. Like for us to comparing like levetiracetam or Keppra for lamotrigine and Lamictal, for us to compare like, is this second generation better than this second generation?
Any other thoughts? Okay. Are there any anticonvulsants or anti-seizure medications that have a large effect on appetite? Yeah, so the answer is yes, and it can be in either direction. As Dr. Haykal or Dr. Allarakhia, do you want to talk about that?
So most medications are probably weight neutral, appetite neutral, but some can suppress appetite and result in weight loss. Big examples are topiramate or Topomax and zonisamide or Zonegran. And then other medications can increase appetite and cause weight gain. An example is valproate or Depakote, also pregabalin or Lyrica, gabapentin, or Neurontin. So something to be aware of in patients who have, eating disorders or obesity, or who need to either gain or lose weight.
Anything else to add? Okay. If stimulants are generally okay with anti-seizure medications, what about drinking coffee or other caffeinated beverages? It's a good question.
To my knowledge, there doesn't seem to be any interaction between, taking coffee or tea or even chocolate and anticonvulsant medications. But caffeine taken in the second half of the day can affect the sleep. So that should be kept in mind. If a person doesn't get enough sleep, they may be prone to more seizures. Sleep deprivation is a very big trigger for seizures.
Right. And certainly there's some people who may just be a little more sensitive to caffeine, and if that is the case, and you find that it is a seizure trigger, then certainly in that case, it would make sense to limit it or avoid it. Another question was related to the rescue medications. And the question was whether that could be used by a person in a store, like if they were in a store in a public place and went into a seizure. The question is the answer is they can be used really anywhere. They're designed to be administered by lay people without medical training. You do need to, be trained on how to use it, but usually a neurologist can do that. But it would not necessarily be something that a bystander who is not familiar with the medication you would want to use, right?
I agree, Russ. It cannot be a bystander who's not familiar with the medicine at all. It's very easy to use, but you have to know how to use it. You basically just push the plunger into, you just get the tip of the device that injects the medicine into one nostril, and then you just push the plunger. But I wouldn't expect a person who's not familiar with the medicine at all to know how to use it. But definitely a family member, a teacher can do it, a friend, anybody who's aware of the diagnosis and aware of the need to use the rescue medicine and just knows what it is and how to use it can do that. So it's definitely not complicated, but I don't think a bystander would be able, without having that background, would be able to administer it.
Okay. We have another person who mentioned post-surgical depression. Which can be a thing that can happen. And so is there a particular medication that would be specifically appropriate for post-surgical depression, or is the treatment decisions related to depression, are they made regardless of whether it's pre or post-surgical?
I don't think that there is a medication that specifically works for post-surgical depression. I'm not a psychiatrist, but I'm not aware of that. I think you have to consider a patient's diagnosis, severity of depression, et cetera, what medication they've been on. I think the approach is similar to, treating any case of depression.
Maggie, were you going to say something?
Yeah, I was gonna just add that you have to keep in mind the pharmacokinetics of the antidepressant that we're adding, because I'm not familiar how long the depression might last after surgery, but if it's for a few weeks, like you want to make sure like an SSRI can take up to 12 weeks for it to take its full effect. So just something to keep in mind, looking at the pharmacokinetics of the antidepressant that you're adding.
That's a good point. Right. Another question I have is, based on the literature and your clinical experience, how would you characterize the risk of switching from brand name to generic anti-seizure medications, or from one generic manufacturer to another? Like in cases where insurance requires high out-of-pocket costs for brand name medications, what can be done to minimize the risk of either side effects or seizures, so that patients can feel comfortable making the switch to a generic?
No, the specialist can correct me if I'm wrong, but I think there was a switch about, in the opinion of the organizations like the Neurology Association and the ANA, about switching. First, they used to be against it, and I think I was in pharmacy school when that was the norm. But I think it recently switched to being more okay with us switching from a brand to generic, but I think it's more ideal if you stick to one like manufacturer when it comes to generic. Correct me if I'm wrong.
In general, I recommend, sorry, go ahead, Dr. Allarakhia.
Please, Dr. Ayman. Go ahead.
In general, I recommend sticking to one formulation of the medication, same manufacturer in general, as a general rule. Now, sometimes this is not possible for a lot of different reasons, usually insurance-related reasons. But there were studies looking at patient switching, comparing brand name medications with generic medications. There's no evidence that brand name medications are superior to generic medications. And most patients are able to make that switch safely and without a problem. But there are some patients who might be sensitive to very mild changes in medication level, and sometimes switching from one generic medication to another generic medication, so from one manufacturer to another, can result in small differences in the serum level of the medication. And for some reason, it seems like some patients are really sensitive to that subtle difference in the serum level, and they can experience either side effects or change in seizure control as a result of that. In general, I think this is not very common, and most of the time we're able to switch without a problem. The answer is I would prefer that a patient sticks to one manufacturer, one medication, and not change anything. If a change is a must, then we just do it, with caution, watch for, just make sure the patient is aware that, things might change. And if they do change, then we have to go back to the previous formulation or check levels. And that's another, method we can, you both reassure patient and make sure that there's no disruption of seizure control by checking the medication level. So in the blood before and after the switch.
And if you do some medication level checking, if you just do that for a short period of time, is that typically enough to feel confident that it's gonna work, or is there possibility of that changing over time?
It depends on the half-life of the medication, but in general, after you switch, you can probably a week after, you can check the level, and that would represent the new level of the medication. So it depends. The timing of the blood draw might be different depending on the medication you're on. But again, this is not very common. In the majority of patients, we switch medication and we don't have problems. And in most cases, we actually don't. I do not personally check levels.
Okay. Jenn, did you ever have to make a decision between generic or brand name, or? due to insurance issues or anything?
No, we have really good insurance that will cover whatever we need, but we go to a small pharmacy and with 2 pharmacists that really know Aubrey and are very aware of my concerns with that. So even if they change like the color of the medication, they make me, they let me know. And I think they're very cautious, and I appreciate that they're looking out for her too. So it hasn't been an issue that we've had to change at this point.
Right, and I think that raises a really good point. If you can have a good relationship with and get to know your local pharmacist, they can be a huge assistance when it comes to that, making sure that there's consistency and alerting to you if there has to be a change for any reason. So.
Yeah, I'll just add that a lot of times generic medications are switched from one manufacturer, to the other without the patient knowing. So it is good for patients to be aware of that. And in general, again, it's a good idea to stick to one manufacturer. It doesn't mean that you can never switch, but switching back and forth from one formulation to another, in general, doing this frequently is not a good idea.
Right. So another question that this comes up often is concerns about long-term side effects of medications. And by long-term, I'm really thinking about like potentially irreversible side effects or changes that would be seen over a long period of time that might in some cases be reversible, but might in some other cases be irreversible. Can you talk about some of those, like bone density being one that pops to mind, but what are some of the potential long-term effects of being on medication, anti-seizure medications for a long period of time?
What the common thing, particularly in my clinic, because it was a geriatric patient population, so you're looking at least someone who's 55, and a lot of them, they come to us, they're already on phenytoin, phenobarb, carbamazepine, and they are stable, although the goal is always to wean them off and switch them to a newer drug. But sometimes when they're stable, we have to assess the risk of long-term adverse effects. And like you said, osteoporosis is a common one. So most of these patients in my clinic, the physician would order a DEXA scan to assess their bone density. And I would say most of the time, even without ordering the DEXA or waiting for the results of the DEXA, we start them on a vitamin C and calcium supplementation right away to be taken long term. And if the DEXA scan comes back and they do have osteoporosis, most of the time we're referred for their primary care physician to write a note, so they can be started on something for that.
Other thoughts on that?
Yeah, long-term side effects are probably more common with first generation or older medications like phenytoin and phenobarbital. Fortunately, they're much less common with the newer medications. So I would say that there's a probably majority of our newer medications, if you're tolerating them well and not having side effects now, you're not going to develop side effects long-term if the dose is not changed. So, and that's true for probably the majority of new medications. The older medications like phenobarbital and phenytoin or dilantin, you need to watch for some more serious side effects. One that comes to mind that happens with after long years of exposure is atrophy of the cerebellum, back part of the brain responsible for balance, and that sometimes can happen after being exposed to these two medications for a very long time, and that can cause issues with balance, for example. With phenytoin, sometimes you see that gum swelling or gum hyperplasty, which can lead to dental problems. So monitoring for these side effects is important. So good dental hygiene and regular visits to the dentist in the case of phenytoin, for example. Osteopenia or osteoporosis are also older generation anti-epileptic medications. I can't think of others, but there are rare side effects. There's some literature linking to phenytoin to increased risk of neuropathy. although some people question that. But fortunately, that's not an issue with most newer medications.
Yeah, there's a follow-up question about oxcarbazepine or Trileptal. Does that, because it's similar mechanism of action to Tegretol or carbamazepine, but does that avoid the bone density issue as a newer medication, or does that have the same risk?
So the oxcarbazepine is also mildly, not as much, but still does have some enzyme induction effect. So it induces the, cytochrome P450, but maybe to a lesser degree compared to the carbamazepine. So any drug which induces or increases the turnover of other drugs by inducing the cytochrome P450 system in the liver can in the long term lead to, osteoporosis. So it has to be monitored.
And Dr. Allarakhia, just as a follow-up question in terms of long-term side effects, there is another common concern that I hear from parents about anti-seizure medications. Will they interfere with brain development in any way? Is there any evidence to suggest that they can do that?
All medications can have cognitive and mood side effects. So even though we may focus on the older ones, but even the newer ones can have a subtle effect. So I think it's important to monitor in the short term. I'm not sure if the long-term effects are different from the short-term effects, but I think we have to keep our mind open and consider with every seizure medication, whether or not even if there's even a subtle cognitive effect, and does it affect learning? Does it affect attention and concentration? Does it affect the mood? Does it make someone more sleepy during the day? So all those things can potentially affect the learning in a child, and I don't think it's the short-term effects are necessarily different from the long-term effects. Except that the long-term effects may be cumulative.
Right. Quick question in terms of Ativan versus Valium, or lorazepam versus diazepam, if I'm getting that right. In terms of rescue medications, does one of them last longer or act more quickly than the other? Can someone just briefly mention the difference in how they're the pharmacokinetics for those?
What were the drugs again? Sorry.
Ativan and Valium as rescue medication.
Okay. Given their route of administration, I would say they both have faster onset of action just because of the route of administration. So I wouldn't necessarily say one lasts more than the other.
Yep. So currently, Ativan is not available. You can give Ativan IV, but as a rescue medicine at home, only midazolam and diazepam, which is the generic of Valium, are available as intranasal treatment, and then diazepam, which is again generic of Valium, is available as Diastat, which is given rectally. But I agree. There's no difference in if you give them IV. I don't think there's a difference in the onset of action. In general, I think the effect, although both have a long half-life and stay in the system for a while, I think Valium, the effect of Valium might be shorter in duration than Ativan. That's because it redistributes in fat tissue. So after it's given, it's redistributed to fat tissue, and that less of it is available in the bloodstream in this case. But currently for home rescue therapy, Ativan is not an option, or lorazepam is not an option.
Yeah, and there's also there's clonazepam or Klonopin is another that might be used as a dissolving wafer, can be used in some circumstances as well.
Right, and that would also be slower in terms of, so if medication is given orally, obviously, absorption is going to be slower and probably less reliable than the intranasal route.
Yeah. Oh, and so I had a few more questions. We couldn't get to them, but I will try to respond to these after the fact. But really appreciate, we covered a lot of ground, and I thank everyone for their input. And as I said, if we have other questions that I'm not able to answer, I might be reaching out to you for your assistance so we can get these questions answered for our participants. So thanks everyone for submitting your questions, and thank you to our panelists. We really appreciate your thoughtful responses, and I think we covered a lot of really important aspects of medication. So thank you everyone. We're gonna transition now to the last session of our conference. And the title is Nurturing Mental Health in the Midst of Uncertainty. Last session of our conference. And the title is Nurturing Mental Health in the Midst of Uncertainty. And we are pleased to have as our panelists, Andrea Thomas, who is a psychologist from the Henry Ford Comprehensive Epilepsy Center, and Renee Roederer, who is our helpline consultant at the Epilepsy Foundation of Michigan. Let's see, Renee, I can see you, and I know Andrea is joining us by phone. Andrea, can you say hello? I just want to make sure we can hear you.
Hi, Russ.
Hi, Andrea. Okay, great.
Hi, Renee.
Hello.
Okay.
And hello to everyone.
Great. So can each of you just briefly describe your background and kind of your experience with this topic? Andrea, do you want to go first?
Sure. Well, I've worked with epilepsy for my entire career. My first job out of school was with the Epilepsy Foundation of Michigan. And I was there for many years as their psychologist. And for the last 18 years, I've worked with the Henry Ford Comprehensive Epilepsy Program in Detroit. So I've always been very, very closely aligned with epilepsy and with, of course, all the psychological issues that go with it.
And you have particular interest in trauma and psychogenic non-epileptic seizures as
oh, yeah, yes, yeah, absolutely. That has really become kind of a focus and a specialty because psychogenic seizures are as real as any other. And trauma is something that is a very, very common thing that I deal with everybody, regardless of what their other issues might be.
Great, thank you. Renee.
Yeah, this is a topic that's very near and dear to my heart, both professionally and personally. Here at the Epilepsy Foundation of Michigan, I really have the privilege of accompanying a lot of people as they share with me things that are going on in their life, sometimes in regard to mental health and also in their social health and relational health. My background before coming to the foundation was as a community chaplain and also as a Presbyterian pastor. I've worked in 3 congregations. So a lot of my work has been in community formation and development. And so in that role, I've always been in this place, this position that I really feel has been a privilege to really hear what's going on in people's lives and to listen to them and to accompany them as they process and grow and all of that. Personally, this is a part of my life too. I am a trauma survivor myself. That led to complex post-traumatic stress disorder in my life. Complex means that trauma has been long-lasting. And so that's been a part of my own journey. And I had a really deep episode of depression in my mid-20s. And so I wear that hat also as someone who's had epilepsy too, and also in childhood. And all of those frameworks are important for me in my work and in my life. Yeah.
Thanks. So, boy, 2020, I can't think of a time in my lifetime really where I've been confronted with uncertainty from as many different sources as I have this year. And I suspect that's the case for many people. So many crises and challenges have kind of converged at the same time. It's hard to keep track of them all. And many people have been affected directly by these crises, whether it's losing a house or a crop to a climate-related disaster, or losing a job or a loved one as a result of the pandemic. Those of us who haven't yet been substantially impacted face varying degrees of fear that we will be. And we all carry the weight of the suffering of others and all of this collective uncertainty to some extent. So can each of you share your observations on how uncertainty related to the current national and global crises that are occurring is affecting people around you? Andrea, do you want to go first?
Sure. I mean, this is something that none of us were prepared for. I mean, we heard the words pandemic, but nobody had experienced anything like that in any of our lifetimes. And I remember when I was told I was going to start working from home and having virtual contact with people, as I was closing my office door, it was March 20th, I thought, I'll probably be back in a month or so, which was a naive thought, but I had no reason to think otherwise. And the reality sunk in over a period of time. I realized when I started talking with people just how much all of what was going on in the world, in the country, and in their lives, how it was affecting them. And I also realized that the phone calls became a lifeline, a needed connection to something that they were afraid they were losing. And I think both Renee and I have some similar views on what that was like, because we both talked to some of the same people, and they depend on those contacts for support and reassurance. And when people started realizing they were dealing with tremendous losses, it just came on top of everything they were already dealing with. And so it just made a bad situation that much worse. And so it's actually been a busy time. Working from home for me is back-to-back sessions every day. And, the need to be that lifeline for so many people.
Right. Thanks. Renee?
Yeah, I mean, 2020 has kind of felt like a big this is fine dog meme, if you know that meme. Absolutely. And just to say, really just the news cycle is enough. Just that is enough to really inundate people with stress and anxiety. But when you add to it on top of that, for some, lost jobs, and sometimes with that means a loss of healthcare, or at least a transition of healthcare, the systemic racism that some people are experiencing in our country, loss of loved ones, or fear of that, or perhaps just seeing more illness. It's a lot. And then you think about this pandemic, it becomes so cliche to say like, oh, it's unprecedented. We've heard that so often, but it is. We've never lived this before collectively, and it's disrupted everybody. And then of course, for some, it's upended some people. And so I think on top of that, the challenge of not being able then to be gathered in many of your support systems when you're facing challenge, I mean, that has added a lot. But I will say one way that I think something I've learned personally, and maybe I've seen in some others too, is you can have so much going on in your own life, personally and collectively, that you sort of are brought to a forced orientation to the present, where you're just living in the present, because that's really all you can take in. And sometimes I think when you arrive there with a little bit of time, you go, oh, wait, this is kind of how I want to live, or that sense of being able to challenge yourself and invite yourself to find what's going well, what's beautiful in front of you, what gives you joy, being able to choose that as much as you can. And we can be honest, sometimes it's so flattened, we don't even know how to choose that. But also to say, like, in all the inundation, just to take it in small pieces, like, this is enough for today. I'm just going to stay in today. And that's a discipline that takes some work. But I also think it can be kind of life-giving, both in the positive sense and in curtailing some of the negative waves. I've found that to be helpful.
Right. Right, really good points. Andrea, can you talk about the psychological and physiological connection between uncertainty, stress, and anxiety and mood disorders?
Absolutely. You may need to shut me down, actually, because this is something that I talk about a lot with my patients, and I have a lot of, strong feelings about. So uncertainty by definition, doubt, not knowing what's ahead, having limited knowledge about things that are going on. And as Renee said, you can be inundated with too much information, and you can also feel like you don't have enough. And the thing about stress is it's very misunderstood. People think, oh, stress, it's a psychological state of mind. Well, to an extent it is. Depression, anxiety, they are a psychological state of mind, but stress is very physical. And that is the point that people often miss, that stress makes you sick, that stress can be the reason why you are having more seizures, why you are experiencing more pain, why you are having other symptoms that are flaring up when you seem to be doing well. Because stress affects the body. The first target of stress is the immune system. Where is our immune system? Well, most of it's in our digestive tract. And so when people first tell me, well, I have indigestion and I have acid reflux, and I have abdominal pain and colitis, and they go through this list of digestive issues, then, I know at that point that the stress is having an impact on them. And people are surprised sometimes to know that stress can do that to them. Depression and anxiety are very physical. People who are extremely tired and they go to the doctor and say, no matter how much sleep I get, I'm always tired. Well, that's a sign of depression. That's one of the main symptoms of depression. So it isn't always an obvious sadness or crying. It is often changes in the body. And there is a huge connection between pain and depression. So the commercials that say depression hurts, that is very true. And so what we always want to try to do is make people realize the importance of not just, getting their stress managed so they don't worry as much, but having, the ability to decrease the intensity of some of those symptoms and take the physical impact away. Because compromised immune system is not something you want to have, but a compromised immune system can be reversed. And, you take control of things. So I always want people to understand the tremendous physical as well as psychological impact of stress.
Right. Renee, anything to add to that?
Yeah, I just say absolutely, and I think about that in my own life too. I think I've lived so much chronic stress, and that has impacted my body over the years. And thankfully, as Andrea said, there are ways that our bodies can be resilient and can heal some of those things too. But compromised immune systems, compromised nervous systems, and it's something to take seriously. And it's a real facet. I think sometimes. I hear people say about themselves and I hear people say about others, and it's really troublesome to me when they're like, oh, it's all in your head. It's like, well, if we forget that our brain is actually a part of our body and not some kind of disembodied shame machine making unreal things happen. This is our body, right? So what happens to us with stress, with things that are going on in our lives, it impacts us physically. Of course it does. And so anything we can do to increase ease, to increase compassion for ourselves and for people around us, I think is crucial. Yeah. Be gentle with those parts. Yeah.
Right. So surveys, both by the Epilepsy Foundation of Michigan and our national office, both showed that that unpredictability was the hardest thing about living with epilepsy. And that can be true even for those whose seizures are well controlled. The primary source of uncertainty is whether or when a seizure may occur, but there are plenty of other sources, including the uncertainty about the future, like will I be able to work? Will my child be able to live independently? Will I ever outgrow my epilepsy? There's uncertainty about others' reactions to epilepsy. Will people treat me differently if they learn that I have epilepsy? Will they know what to do if I have a seizure? There's uncertainty about treatment decisions. Should I stick with this med or try a new one? Should I switch doctors? Should I consider surgery? What if something goes wrong? And then uncertainty even about cause or diagnosis or prognosis. Is this even epilepsy? Do I have something else? Was I misdiagnosed? So that uncertainty is so prevalent in epilepsy. Can you talk about some of these sources of uncertainty and maybe give some examples of how someone living with epilepsy might effectively manage them?
Sure. Well, I mean, uncertainty, has an effect on all of us. None of us likes to be uncertain about things, and most of us really feel that we have far more control over things that are going on in our lives than we actually do. And I think one of the first things that's important for people to recognize is what they can change and what they can't. We can't change everything. We can't change other people. What we can change, if we work at it, is how things affect us. So in other words, you make a choice. Are you going to let something push you over the edge? Are you going to let it trigger seizures? Are you going to dwell on it over and over and over? Or are you going to say, I can't change that, so I am not going to let it affect me 24/7? Because that is a choice. It's not easy to change that. As human beings, we want to have control. We want to be able to, make whatever decisions we can make. But at the end of the day, we can't always do that. Don't forget about past success. Don't just look at how bad things are going. Think back, take a step back and think about things that have gone well. Probably one of the most important things is, I think, self-care. We tend to ignore ourselves. Some people are very driven by, what they can do for others, wanting to always be able to fix things. And take care of problems that other people have. But self-care is not selfish. Self-care is necessary. I tell my patients over and over and over, if you don't take care of you, you can't take care of anybody else. And so you have to think about that. If you run yourself down and you end up becoming ill, then what? How are you going to help those other people? And is there going to be anybody there to help you when you need it? So self-care, self-kindness are important things that we all have to take time for. That's part of the balance in life. Of all the important things that we have to do that take up our attention, we have to make sure that we're giving enough time to be good to ourselves and do things that bring us pleasure, do things that make us feel good, and not think that we don't deserve it. So, self-care is really important, and also getting support from people that you can trust. Don't ask everybody you know what to do about something, because you're going to get so many different opinions, and that just makes it more complicated. But if you have a support network, people who you feel comfortable talking about your concerns with, let them weigh in. You still may not take everybody's advice, but at least you are going to trust the source of that advice, and that's going to be more helpful.
Right. Renee?
Yes, absolutely to all of that. I think, Russ, you voiced so well all of those swirling questions that come with an epilepsy experience or an experience of psychogenic non-epileptic seizures as well. And I think just to normalize, like, okay, lots of people ask these questions. Lots of, just to know you're not alone in asking those kinds of questions. And in that uncertainty, I think about a lot of folks, including in our community, who may go a while with seizures under control, and then, there's another one, or kind of get back into a period of that. And just to tell yourself, truly, I think like in our minds, we know, like, that's not a failure, but to keep letting that, be a part of our narrative that we're telling ourselves, that we're lifting ourselves up, and it's okay. I think another thing I might add too is, what do you want to come back to when things are so uncertain? What's foundational for you? And I think in those questions you asked, Russ, this may sound like a cheesy thing you'd put on a motivational poster, but value and values, meaning, like, no matter what, I have value. No matter what, my child has value. No matter what, my family member with epilepsy has value. I, as a person, have value. It can't be lost, dependent on all the things that are shifting in my life or our lives, but also the values, the things that you want to live, that you really hold dear to yourself, ways that you want to live actively in the world. Like last night, we heard this wonderful question from John and Haley Scheinman about, what is your backstory? Meaning, I think they were trying to help us. What is it that gets you passionate? What is it from your experience that you want to see also change? And how do you want to get involved in that? I think with that, what's your resilience story, right? And to keep telling yourself that, and what are the values that are a part of that you can keep living again and again and again, so that no matter what happens, no matter what's uncertain, no matter the questions that swirl that we don't really have answers to yet, like, we have value and we have values that we're going to live. And I think coming back to that again and again is important. I think Andrea also said so well, like, there are things we can't control, and learning how to sift out what are the things we can control and what are the things we can't. And just, it doesn't mean we suddenly don't have anxiety about those things we can't. That's there sometimes, but to then put our primary focus on the things that we can, I think is empowering and can help us feel as though we are subjects and actors in our lives, not just people that are having things happen to us.
Right, exactly. Yeah, and if you can kind of push those things that you can't control to the side and really focus on those that you can, there's a lot of resources to help you better control those things, so in addition to a lot of what we discussed in terms of uncertainty, there's also numerous risks associated with epilepsy, including the risk of SUDEP, the risks associated with certain activities like swimming or driving, and the risks of different treatment options. And assessing risk is notoriously difficult, and this creates uncertainty. Am I making the right decision here? And what are some effective ways to think about risk in order to make effective decisions and reduce uncertainty?
Well, risk is a funny thing. We often think of risk first as taking chances that may not be safe, chances that we'll regret. By the same token, it's the risk takers sometimes that develop the new things that are helpful to people, or can lead to a more positive outcome, or to something unexpected. So yeah, you have to kind of weigh it carefully. The biggest thing is, I feel, to not make a sudden decision about something. When you have epilepsy or even non-epileptic seizures, you're dealing with losses. You can't drive. People are telling you that, you don't have what you thought you had, and now they're recommending a different approach to treatment. You have to be able to step back and think about what you're hearing, not make a decision based on impulse, but make a decision based on the facts. And you can't do that if you are uneasy, if you are, debating, oh, what should I do? If I do this, it might be wrong. If I do that, it might be wrong. You have to give yourself some space, and you have to be able to weigh the pros and cons. And so, and I used to work with children exclusively. Every parent would say, I don't want my kid to ride a bike. I don't want my kid to play football. I don't want my child to do this, that, or the other. And, it was important for them to realize that they couldn't put a bubble around that child. That child was going to fall off their bike. They were going to have injuries, but it was all in how safely do you manage it? How much do you find out about what they can do? How much support do you give them? How much safety, the safety measures that you take. And so it was hard for a lot of people, but it's important. It's important to remember that epilepsy is something you have, and it's not who you are. Because if you identify too strongly with a disorder, then that's your identity, and you're closing yourself into a box and giving yourself a very narrow perspective on life.
Yeah, Renee, thoughts?
Yeah, just a few things I'll add. I think, really listen to your body. And if you're feeling uneasy with, the idea of making a choice to do something, maybe that means that's not for you, or you're not ready yet, and that's okay. But also I really liked what Andrea said too about flipping the script on what risk is. Yes, we do need to take very seriously safety risks and things like that, but we think about risk as such a scary word, but it also can be trying new things. It can be challenging ourselves. It can be opening ourselves to new ideas. It can be, connection and community in new ways. Those are the kinds of risks that are life-giving. And sometimes my best mentor, Ben Johnston Crace, who also lives with chronic illness, he's got very serious cancer. He talks a lot about making micro risks in your life. Choosing little risks, that can kind of help you create a culture within your life or within, a community of being able to take larger risks in the positive sense. But yeah, listen to yourself, tap into yourself. And, I think also like in identifying with illness and disability, I think sometimes we think a lot about loss. And maybe there are some loss of things we can do, but what are the gains too? I think there's some positive too to identifying with what we have gained through disability, what we have gained through illness, and some of those things that have expanded our thinking or allowed us to be in community and relationship in new ways, and that can be a positive thing. And so it's not always loss and bad risk. There's also gain and new good risk.
Right, and I like that term, micro risks. That's good. And taking risks and failure too can be character building, and it can build resilience. And so that I think that's just in general a good rule, is to not be afraid to try something and fail.
Allowed.
Yeah, for sure.
Right. So uncertainty can also be a byproduct of information overload, including increased exposure to disinformation. There's so many sources of information, it's hard to know who to believe, and it's hard to decide which issues you're going to spend your mental energy on and which you're going to ignore. It's also hard to free yourself from the mental processing of all that information that's occurring both consciously and subconsciously. So what are some practical strategies to prevent information overload from affecting our mental health?
Yeah, I think there's never been a time when we've had more of that kind of thing, information overload, than in the last, well, I'm also going to say the last 11 months, because when did the pandemic start? We've also we almost lost sight of that. But way back in the spring, when people knew very little about what was going on, and suddenly we were inundated with information about, some of it legitimate and some of it not. I think that's been another major problem in the country this year, is that the false ideas, the misrepresentation, the misinformation. And I can't tell you how many people have said to me, you know what, I limit the time that I watch the news. Or some have actually said, I don't watch the news any more than I have to. Maybe on the weekend I'll get caught up, but I just can't deal with it. Because when we're hearing conflicting information and we start wondering, well, okay, what is true? Even something like, the whole issue of a mask, where, it became such a political thing. And I have often found myself in my phone sessions with people, treading very cautiously, because someone will have a very adamant opinion about something, and I have to be careful not to contradict strongly, or not to say, oh, you're wrong about that, because it's hard. We've got information coming at us from every direction and through all of our senses, and we get bombarded. And normally we can filter out the things that are, possibly not true. But when you get stressed, or when you are anxious, the brain doesn't have the capacity to do that. It gets overloaded. And so sometimes you just have to take a step back, turn off the electronics, do something different, listen to music, read, but read something that's going to be pleasurable. Don't read about more of the problem, but find things that give you a break from all of that and allow you to kind of, bring down the tension level, bring down the stress level, and, sort out what you're going to allow into your mind and what you're going to believe, and what, again, it comes down to what can you do about some of those things? Possibly nothing. So you have to, have some control over what you pay attention to.
Renee?
Yeah, absolutely. And yeah, it's okay to limit that information. And I think there's a difference between being informed and being immersed. And
Absolutely.
there was a period of time, I don't know, maybe it was a month ago, where I realized how deeply immersed I was. And back to that sense of trauma and that sense of stress impacting your body, I really started to get sick. I mean, really. And I was like, whoa, I gotta quit this, So I do want to be informed, but, limiting how I do that and making very conscious choices about that is important. As for disinformation, I mean, I think another thing I'd like to add is to ask ourselves, why is this here? What is this? What response is this trying to evoke in me? And why and how? Sometimes disinformation is just misguided, right? And that can be challenging, but if it's also seeking to flatten me, inundate me, overwhelm me, or if it is somehow seeking to get me or whole groups of people to scapegoat people, other whole groups of people, be suspicious about that, and I don't think that my mental health is benefited by scapegoating whole groups of people, but the bigger danger is that people are being scapegoated. And so pay attention to that stuff. There's a lot of stigma out there in a variety of ways. And we as a community certainly know what it's like to live with stigma and when people misunderstand us. So to try not to misunderstand our neighbors willingly, but to try to have an open mind and an open heart, and to know that these various things that are impacting certain groups of people in our country and in our world are also a part of our epilepsy community. And so some people are really dealing with this time on multiple levels and multiple levels of stress, and just to say, you know, gosh, I really want to understand my family member. I really want to understand my neighbor. I want to understand, and to keep trying to have as much compassion as we can, to say no to things that are wrong, you know, in terms of like that, wisely at times, things that aren't, you know, aligned with our values, but continuing to care for each other and care for ourselves. And it is okay to turn some of that stuff off.
Right. So closely related to information overload is the idea of the paradox of choice. When faced with the sheer number of choices that we have for even the most mundane decisions, like what type of bread to buy or what type of mustard we'll get, we can be paralyzed by uncertainty. And this uncertainty often persists even after decisions has been made. You know, you can have buyer's remorse or second guessing yourself. So how can people minimize the impact of this type of uncertainty?
Paradox of choice is an interesting phrase, because I think most of us are grateful to be living at a time and in countries where we have choice, where we can make decisions for ourselves and nobody's telling us, you know, otherwise. By the same token, as stress increases, there is such a thing as choice overload. And people can become overwhelmed if there are too many choices to make. It's kind of like, you know, when you're working with a toddler or a very young child, and you're trying to modify their behavior, and you know, you want to give them a choice of, you know, if you do this or you do that, you know, this will happen. You don't give them 5 choices. You don't give them a whole list of things. You give them 2. Okay, if you do this, this will happen. If you do that, that will happen. Or if you're good, you can have this or this. They can't handle making a bigger choice than that. And one of the things that happens is when people are faced with too many decisions, it often leads to self-blame. Because if you feel you've made the wrong choice, okay, who's at fault? Who made that choice? You did. And are you going to beat yourself up because you think, oh, I should have done the other? Well, none of us makes the right choice every single time. And we can't, you know, hold ourselves to that kind of a standard that we're going to make the perfect choice. I tell people all the time that the worst time to make a life-changing decision is when you're stressed, because you get confused. You get caught up in the pros and cons of too many things, and you're likely to react more on impulse than on good judgment and reason. And so sometimes you have to be able to, you know, step back. If the choice doesn't have to be immediate, then maybe make some lists. And then look at them carefully. Give yourself time. That is so important. And don't, you know, look at a list of 15 different options and say, okay, which one of these do I want to choose? Narrow it down. Minimize the possible ways forward. That's the only way you can make a reasonable decision, because, you know, Russ said, you know, picking out what type of bread to buy. I have people all the time who will say that they went grocery shopping and they were there for hours because they simply couldn't decide what brand of something to get, or what kind of clothing they should buy. So we want to try to keep that simple and as much as possible.
Yeah, absolutely. And I think sometimes when we have that paradox of choice, and there are too many, you know, our brain seeks to protect us in some ways and go, what could go wrong, you know, and you're kind of mapping out all of these possibilities. But I think to challenge ourselves into possibility thinking and to say, well, what could go right? You know, because the truth of the matter is sometimes things don't go the way we want them to, but sometimes they go a way we didn't expect that was great, right? And just to say, like, it's okay to make choices and to be with whatever is. It's kind of like, I just thought of this too. If you've ever done improv theater, or you know people who have, or you know a little bit about that, there's this concept called yes and, where somebody presents something to you in a scene and you just say yes to it. You go like, okay, this is what it is, and then you add to it. And there are times in our lives where whether we feel like, oh, I suddenly have less choices than I thought, or I'm inundated with all these, and someone presents us with one, or life presents us with a way, or maybe we made a choice, and just to see where it goes and to know that we are empowered to make different choices. But what could go right? What could go right?
It's also okay. It's also okay to make a choice that's good enough. It doesn't have to be perfect.
Absolutely.
You know, especially when it comes to bread. You know, if you're choosing, you know, whether to have epilepsy surgery or who your provider is going to be or that type of thing, yeah, spend some mental energy on that. But on the ones that don't really matter, just be okay with good enough. Yeah, this will do.
There you go.
So, so as we mentioned earlier, uncertainty leads to stress, and managing stress can involve eliminating or reducing sources of uncertainty. It can involve changing how we think about uncertainty or modifying our body's response to stress. So, Andrea, can you give some examples of these different approaches to stress management?
Oh, sure. One of the underlying issues is that someone allows themselves the time to do stress management, to learn ways to manage their stress. So often people, I mean, the thing I hear so often, oh, I don't have time for that. Oh, no, you don't know what I have to do. I couldn't possibly do that. Well, the alternative is, going back to what we talked about before, is having your body break down, having your health break down, and then what? It's far better to give some time, even if it's limited periods of time, to learning stress management techniques. Oh my gosh, mindfulness. That is a huge thing in my book for people to become aware of and get involved in. And mindfulness, what is it basically? It's being in the present moment instead of having one foot in the past and one foot in the future and totally missing what's going on around you right now, because those are important things too. Our reality is, for all of us, Russ and Renee and me and all of you who are listening, is getting through the rest of today, because we have some control there. We don't over what's coming, and we sure as heck can't change what we did yesterday. So making the time, being consistent, don't start a stress management routine and do it for a few days and say, that's not helping. Relaxation is learned. It is not an automatic response like the stress response. That's automatic. We have it from the time we're born for the rest of our lives. The relaxation response is learned. And so people do themselves tremendous good when they take the time to learn ways to bring that muscle tension down, bring the blood pressure down. And there are so many great ways, cognitive behavioral techniques, again, mindfulness. And so, you know, that becomes all important. Stress management has to be something that we all look to and take seriously and continue to do it. You don't stop when you don't feel stressed anymore, because that's what got you to that point. And if you stop, you're just going to have a relapse of stress. So it's important to make stress management a part of your day. You can choose what part of the day that's going to be. I always tell people, like, you know what, take several small periods of time to do some deep breathing or do some visual imagery or be mindful. It doesn't have to be taking an hour out of a busy day all at one time.
Yeah, thank you. And this is where I also want to do a commercial for Uplift.
Ah,
yeah.
yay, go Renee.
And I have this great great privilege of working together, and we are a dynamic duo. We love working together to do a program called Uplift, which is an 8-week program that we run over the phone, and we do it several times a year. And it is for people who have epilepsy and depression, or perhaps are interested in preventing depression, certainly gaining more stress relief. And so we learn these very practical tools. And if you are, you know, an attendee today, I want you to know about that. I want you to contact us if you think you could benefit from that, because we are right now putting together the list of people that we will contact in 2021. We'll run this 4 times in 2021, and we want you to do it. And to all of our neurologists and epileptologists and other clinicians here, we want you to invite your patients into this, because we have seen as we teach people these tools of mindfulness and cognitive behavioral therapy thinking and other ways of getting relaxed, it changes things. It really changes things for people. Along with that, you know, Andrea so wisely said, our stress response is automatic. So, you know, when we are having that stress response, we go into the 4 Fs. We've probably heard of 2 of them, but 2 are a little lesser known, but very active. Fight, flight, freeze, or fawn response. The 4 Fs. Those are the 4 Fs of trauma. They're the 4 Fs of our stress response, and that activates our sympathetic nervous system. What we're trying to do is learn that relaxation response, which Andrea very wisely said is not necessarily automatic. We have to learn that. That is engaging our parasympathetic nervous system to get it to calm down, to ease that fight, flight, freeze, or fawn response in us. So there are a lot of things you can do, and I think find the ones that work for you. There are a lot of things you can try. That's what I love about Uplift, because we teach people these tools that they can try, and they go, oh, wow, these 3 have changed things for me. I really didn't connect with this one. That's okay, right? But some other things you can do at home. You know what? Give yourself a hug. Sure, you might be like, oh my gosh, if somebody was watching me give myself a hug, I might feel like a fool, but do it because it's good for your body. You know, when you do that, you can even do it right now at home. No one's watching you. You activate, you know, pressure points on your skin, and that, interestingly enough, engages the vagus nerve. We often talk about the vagus nerve in epilepsy because a lot of people have a vagus nerve stimulator, and stimulating that nerve can reduce seizures sometimes. But also, the vagus nerve is super important in activating that parasympathetic nervous system, that relaxation response. There are things you can do with that. Give yourself a hug. Here's an interesting stress life hack too. Listen to birds. This is very interesting. You can literally listen outside, or you can even get a recording going at home. And that activates our parasympathetic nervous system. And some people think because our ancestors long ago, anytime they heard birds, they knew that there were no predators around. So maybe our body has learned to calm down when we hear that. Move your body. You know, one of the things that's interesting about this relaxation response, and also in doing work around healing trauma, is bilateral movement. In fact, there's a whole area of therapy called EMDR, which is about bilateral movement, and Andrea practices that in her practice. But also just like sometimes getting up and walking, or moving your arms from side to side and thinking good things. You know, it's kind of like reprogramming the brain. It's kind of weird that works, but it does. And find your own tools. If you know what works for you, just commit to it, right? We've got to work that into our days. It can make a big difference.
Right. So, and so we've already touched on some of this, but in addition to confronting uncertainty directly, we can also counterbalance it by engaging in thought processes, behaviors, and activities that build resilience and cultivate happiness. So let's talk about some of those. I'll just throw 4 things out, and you can kind of talk about each of them. But positive psychology, social connection, which is very relevant this year. It's our challenge of the year, and obviously the pandemic has impacted that. Exercise and sleep. So can you talk about some of those different ways that we can kind of strengthen ourselves and cultivate happiness?
Sure. I was glad to see that you have gratitude listed with positive psychology. You know, people don't practice enough gratitude. And I talk to a couple of the groups that I do about practicing gratitude, keeping a gratitude journal. You don't always have to have major things happen, huge events to be grateful for. You can be grateful for the smallest things. Renee mentioned hearing the birds sing. Yeah, if it's a beautiful day and you go outside and the sun is shining and you hear the birds singing, be grateful for that. You don't hear that every day. So we have to kind of rethink what we're grateful for and, you know, what gives meaning to our lives. And not overlook, like I will tell patients sometimes, you know, at the end of the day, just jot down something. It doesn't have to be a formal journal, but jot down something that happened during the day that you're grateful for. Maybe somebody said hello to you. Maybe you saw something that made you smile, or something, you know, that made you laugh. Those little things add up. Helping others. There's a great deal of satisfaction that people get from doing something for someone else. It can take attention off of something that you are struggling with, and make you feel good about what you're doing. And then, of course, challenging activities. If we challenge ourselves within reason, we don't want to do something unrealistic, but it can make you feel good about what you've accomplished. Social connection, absolutely. One of the things I hear most from people now is how much they miss seeing family members and friends. But we live in an age of Skype and Zoom and FaceTime, and so we're not totally cut off. It may not be person to person, but we do still have that option. And of course, you know, exercise and sleep. Exercise is not just something you do to lose weight or to build your body. When you do something physical, you release endorphins in the brain, and those are natural mood stabilizers. And this is why somebody can be really upset and angry and maybe go shoot some baskets or go for a swim, and the problem isn't solved, but their level of anger and frustration may come down. And of course, sleep, a tremendous issue, because the danger of sleep deprivation and how it affects a person, certainly someone with epilepsy or with a lot of other medical issues. If you're not getting enough sleep, your brain cannot function, and it's going to change how your brain reacts to things.
Right.
Yeah, those are such good points and good tips. And I'll just add a couple things, but just to reiterate the gratitude piece, it makes a big difference. If that's a rhythm and that's part of your day, I have some groups, multiple groups, where we will begin our time together, and again, over Zoom at this stage, but talking about, you know, our high point from the week and our low point, or we'll call it roses and thorns sometimes. And once you start doing that and you're looking for those little moments that, and you know you're going to share that with somebody, it really kind of impacts how you see your day. You're looking for things. The questions that we ask make space for us to discover new things. And so if we're looking for an occasion to be grateful, we're probably going to find it, you know, and that really does impact things. Thankfully, you know, our brains are plastic, which is kind of a funny word, neuroscience word. It doesn't mean our brains are made of plastic, but they are changeable, they're malleable. We can change in our thinking patterns and our feeling patterns, ways that make our bodies feel more alive, more life-giving. You know, and then the thing I'll just bring home all day long, because I think it is the most important thing in my work, but it's also what has changed my life personally the most, is community connection. I just believe in it, because when we're going through something challenging, connections don't always fix that challenge, but they always change it. That is my motto, I suppose, is that connection always changes things. And I think always for the better. When we're embedded in community, we feel safer emotionally and in many ways, physically and materially. There's a man named Hugh Holloway who started a community of people experiencing homelessness in North Carolina. And I just, was really taken by this thing that I've heard him say multiple times. He says, the opposite of homelessness is not housing. The opposite is community. Because if people were embedded in community, they probably wouldn't have become homeless in the first place. And so whatever kind of challenges we are facing when we're connected to each other, we bear each other's burdens and we celebrate each other's joys. And so I've been really touched at a lot of communities that have been formed through the Epilepsy Foundation, including several that are ongoing and wonderful. We have this Call and Connect community for adults with epilepsy every Thursday, unless it's a holiday or something, but every Thursday from 1 to 2:30 p.m. and people call in, and what's really cool is those relationships have been built over time, and so they really take care of each other, and they'll call each other throughout the week and check in with each other, and it makes a big difference. We have a young adult community for young adults with epilepsy, ages 18 through 25. That's meeting over Zoom twice a month. If you're interested in that, email me, and for any of these, you can email us and we'll give you the information. And to see young adults with epilepsy kind of come alive and having the occasion to have a peer group, right, of people with epilepsy, it's been very life-changing for them. We have a group for parents who have children with epilepsy that meets on Tuesday nights at 8 p.m. over Zoom. You need to register and we'll give you that, and you can come and join us. We just don't want people to think they're out here alone with an epilepsy experience or the many stressors we're living in life. And this is, whatever you might be dealing with personally, this is a time of collective trauma. We are going through collective trauma, so we need each other. It's important. Right,
and that leads into the next question. And we are running short on time, and so let me actually, I'm going to check the Q&A just to make sure that we don't have any questions. Here we go. Someone suggested listening to music, calm music, or singing along to music, and that helps them. So I think that's, again, I absolutely agree with music. Either listening to it or making it is one of my greatest sources of joy and greatest stress reliefs. And everyone has things that they can do: art, music, reading, social activities, sports. Unfortunately, team sports are a little harder now with the pandemic, but that team sports are a great way. But yeah, I just wanted to make sure that we checked our Q&A. We've got a few minutes left. So trauma, as has come up a couple times here, it is often intertwined with both epilepsy and uncertainty. So can each of you just talk briefly about the incidence and impact of trauma in people with epilepsy and some approaches to coping with it?
Trauma is far more common than people think. There are still a few people who think, only if you've been in the military can you develop PTSD, which is totally not the case. And a lot of people have said to me, well, how are you dealing with trauma when you work in the neurology department and part of the epilepsy program? Because 40% of people in almost any hospital outpatient clinic are dealing with some kind of trauma history. Epilepsy itself can be traumatic. I have a couple of patients who have had multiple surgeries. One has a neuropace, they both have the neuropace. Neither one of them are doing well, and it's very discouraging that they've gone through so many different procedures. So just the medical procedures and the treatment can be traumatic. Feeling that you're not going to get control over the epilepsy and how it's affected your life can be very traumatic. And so I do a trauma support group for women at Henry Ford. I also do an art therapy group. Well, we're not doing them now, obviously, because of the pandemic. But both are extremely helpful to people, and kind of combine what Renee has talked about, a community impact, as well as a way to just relieve stress and deal with trauma, because even if you don't have a serious medical issue, if your epilepsy is controlled, if you have a trauma history, it can still be affecting you as an adult, even though things happened when you were a child. So this is how I got into trauma work. It was a gradual process, but it is something I do a great deal of.
Yeah, that's right. And yeah, some of the traumatic experiences we have in childhood can really be correlated with medical challenges later in life. You know, and so, and that's been a part of my own journey. So, I mean, I speak to that, but I also think the community that we build, the practices that we engage, the ways that we relieve stress, that also changes the body and can change life outcomes too. And so I think I'm just like a person who has had such community intervention. I grew up really feeling alone, and my childhood and young adulthood had a lot of deep, deep trauma in it. And just having people who come along in your life and have a place where you belong, where you can grow in your strengths as a person, where you are accepted as you are, your needs are valued, it's life-changing, right? And so I think lean into the people who love you, you know, and also to know that we are here for you. We want to be one major piece of that community growth and resiliency in your own life. We're here for you. So we call it the Here For You helpline, but we're here for you as a foundation. And we want to, and to say, as much as like we who may be at sort of the hub of working at that foundation want to be here for you, the truth is we are a large community of people who you know, exist around the state, who are people with epilepsy, people with non-epileptic seizures, people, you know, who have all of that strength and all of that experience, and who can provide care for each other. So that's what we're seeking to do, and I think that's life-changing.
Thanks so much. And one more comment that came through the Q&A was the idea of art therapy, and we did used to have a program called Studio E, which is very beneficial, and we are hoping in the future that we can get back into offering something like that. I will mention for those in the Grand Rapids area that Mercy Health Howenstein Neurosciences has an art therapy program that you can definitely check out. I'm not sure of the status of it now with the pandemic, but that has been running for a long time, and art therapy is definitely another very beneficial activity. So thank you so much, Renee and Andrea, for a really in-depth and ultimately uplifting conversation and discussion. So really appreciate it, and hope everyone can take something that they learned today and help, you know, again, to, as the title says, to nurture their mental health. It really needs attention, and I hope everyone will take the time to do that.